Croft. Good. Comfortable?
I just need to get a few documents out.
Surely. Good, thank you. Now, good morning everyone, and first of all, thank you for attending this presentation, which is the first public gathering of the Scottish COVID-19 inquiry. The purpose of today's presentation is to hear a report prepared by Dr Ashley Croft on the epidemiology of COVID-19. It is a presentation. I use that word deliberately, and it is not a hearing where there will be opportunity for anyone else apart from Dr Croft to participate. Be well aware, however, that you will all, or certainly co-participants, will get the opportunity to participate at later hearings, I imagine on more than one occasion, in relation to epidemiology and any other matters. Because the inquiry will be hearing evidence from a number of other sources in relation to the epidemiology of COVID-19 on a number of occasions throughout the coming months. I should also indicate at this case that the first public hearing at which co-participants will be offered the opportunity to participate will be a preliminary hearing to be held at Meadowbank Stadium in Edinburgh for 2 days. We've deliberately allowed 2 days because we appreciate people may have a lot they wish to contribute, on the 28th and 29th of August. For core participants, I can inform you that you will receive a letter very shortly at the beginning of next week, which will outline the format of that hearing and will also give you more details in relation to the conduct of it. So with that very brief introduction, I should indicate that the other participants today will obviously be Dr Croft, the author of the report, and lead counsel on this part of the inquiry, Stuart Gale KC. The hearing or the presentation has been set down to, or we have available 2 days, and I understand from Mr Gale that it's probable that we will need 2 days, although we may finish a little bit earlier tomorrow. During the course of today and tomorrow, we will have a number of breaks. We'll have a break both this morning and this afternoon, both for the benefit of Dr Croft and Mr Gale, but also obviously for the convenience of the audience. So with that explanation, I would invite Mr Gale to begin his examination of Dr Croft. Mr Gale.
Thank you, my lord. Good morning, Dr Croft.
Good morning, Mr. Gale.
Just some introductory matters to begin with, please, so that we know what we're dealing with. You've provided the inquiry with a report which extends to some around about 70 pages. And attached to that report are a number of appendices which take us up into the hundreds of pages. And you've also provided us with a total of 22 scientific papers, which have also been made available on our website and to core participants. My intention today and tomorrow is to use your report as a guide to take us through your presentation. So everything will largely be under reference to what is in your report. Occasionally we will divert into some of the documents, but at those points I will make it clear that we are doing that so that you're able to follow that. So, Doctor, can I begin with some formalities? Your full name is Ashley Marshall John Croft.
Ashley Marcel.
Marcel, do beg your pardon, first mistake. And for present purposes, you've provided your CV, which is contained at Appendix 2 of your report, and extends from pages 80 to 100 for those who want to follow it. For present purposes, you've given an address at Consulting Rooms at 10 Harley Street in London.
Yes.
You've also provided, I think, your GMC number.
Yes.
How old are you?
I'm 70 years old.
Thank you. Now, at the beginning of your CV, you tell us that you are a fellow of the Faculty of Public Health Medicine of the Royal College. Is that correct?
Yes, that's quite correct. Which page is that?
Yeah. Just a minute. Be on my notes. It's at page 82.
Oh, that's right, yeah. Yes, on page 82, my lord, 5 blocks down, professional body, Faculty of Public Health Medicine of the Royal College of Physicians of London. And it is quite correct. I'm a fellow of that by election. I became a member by examination in 1995, and a few years later was elected a fellow.
Now that organisation, it may be self-explanatory, but could you tell us what qualifies you for membership and then fellowship of that organisation?
Yes, the Royal College of Physicians of London is a long-established Royal College which has a membership consisting of qualified physicians, and they have to pass examinations and prove their competence. And there are various subsections of that Royal College. One of them is a Faculty of Occupational Medicine, and quite a recent subsection is the Faculty of Public Health Medicine, which came into being about 40 years ago. Originally was called the Faculty of Community Medicine, but the name was changed because I don't know, I think community medicine was a better name. So the two terms are sometimes used interchangeably. And to become a member of the Faculty of Public Health Medicine, nowadays they tend to call themselves the Faculty of Public Health. You have to pass examinations, Part 1 examinations, in the various specialist disciplines of public health. In my day, the core disciplines particular to public health were medical statistics, epidemiology, communicable disease control, health promotion, health economics, and sociology. So it was common to go on a master's course to prepare yourself for those Part 1 exams, which were very hard. Later on, I was a Part 1 examiner, but I passed those exams in 1992, I think. I've got it down here. And then became a member. I'm so sorry, I didn't become a member. I passed the Part 1. There's then a Part 2 for the membership of the faculty. And in my day, that required you to do 2 big projects and 2 big reports, similar to this report, on some aspect of the work you were doing. You were meant to be training in-house and doing public health tasks under supervision, and you could choose any 2 things that were of interest. The idea was they had to be different. One of them was expected to be communicable disease control, because that's important, very important in our area. So I prepared two projects. Would you like to know what they were?
Yeah. Yes, please.
Okay, fine. First one was I looked at, I was working for the army at the time, and there was a concern about pregnant service women, that's to say women who were in the Army, Navy or Air Force, because up until about 1990, if they became pregnant, they had to leave. There was no facility for pregnant service women in the forces, and then this was deemed, this was challenged in the European Court, I believe, round about then, and it was deemed, considered illegal to ask women to leave, quite rightly, if they were pregnant. So the problem arose as to how could they be employed safely when they were pregnant and breastfeeding. And so this is a big problem. So because I was the newest arrival, they said to me, right, sort it out. So for about a year, I did literature searches and consulted various authorities and produced a report for my department, my Army department. Army department, yes, it was the Army then, and this became Army policy. I then wrote it up as a scientific paper, which we're encouraged to do, and it's one of my first, I think it's my second research paper that's in my CV. Croft AM, The Employability of Pregnant and Breastfeeding Service Women, Journal of the Royal Army Medical Corps, 1995. I think a lot of that is still in military policy. So that was basic epidemiology, really, just looking at all kinds of environmental, infectious disease, ergonomic, occupational factors that might damage the health of service women, and trying to find some way in which they could be accommodated with pregnancy, or not, as the case may be. And then for my second report, I was rather keen on Legionnaire's disease, and we'd had an outbreak in the Army Computing Centre in Worthy Down in Hampshire, and it had closed down the Army Computing Centre for 2 days, which meant for 2 days the Army couldn't actually function. So I was keen to do that, but I was told, no, don't do that. We want you to go and look at a new anti-malaria drug that's just come in called Lariam, and just go and evaluate it. It's a really good drug. So I thought, okay, I wasn't interested in malaria then, but I thought, well, you do what you're told in the Army. So I set up, well, because I'd been trained in epidemiology, I knew the right way to do an evaluation of a drug or a service or a vaccine is to do a randomized controlled trial. So in 1993, I did a little pilot trial in soldiers going to Kenya who were taking this new drug, and that went well. Then in 1994, I set up a full-scale randomized controlled trial of this new drug. And the study population were the 1st Battalion of the Grenadier Guards, who were going to Kenya for 6 weeks. There's malaria in Kenya, so there are about 640 in the population. And so I should have said I got research ethics approval, obviously. And so they were randomized into 2 groups. The first group were randomly allocated to receive the new drug, which they would have got anyway, actually. And then the other group were randomly allocated to receive the old combination of drugs that they would have got the year before. So I did this trial, and this is relevant, I think, to what we're going to talk about later on. But it was a bit unsatisfactory because the soldiers going out to Kenya were given a questionnaire on week 2, that's at the point where they were flying to Kenya, and then again at week 8 when they were flying back. And I entrusted the questionnaire to the Royal Air Force, who were flying them from Price Norton. And I didn't get a very good response. I got about a 56% response for the first questionnaire and a 48% response rate for the second questionnaire. So that's not really very good in a randomized controlled trial. You want to aim for 100%. So and another thing that was odd about it was that a lot of the soldiers, one of the questions was, have you been taking the drugs correctly? And about 17% of them, even though they were responded, admitted they hadn't. So this raised concerns. But anyway, I wrote the study up, and it was published in the Transactions of the Royal Society of Tropical Medicine and Hygiene. I'd offered it to the British Medical Journal, and they said, well, Dr. Croft, Major Croft, this is interesting, but normally we expect a response rate of about 60%. When it falls below that, when the dropouts are so high, you can't really necessarily ascribe validity to your results to the degree we wanted. So anyway, so I then did the following year. In the meantime, I passed my Part 2 exam, putting in my pregnant service women paper and my my malaria paper, but I thought I'll do another randomized controlled trial just to sort of get to the bottom of this problem. Why are soldiers throwing away their drugs? And this second trial took place in between October 95 and January 96. And the trial participants were the Princess of Wales's Royal Regiment, based in Dover. And on this occasion, I went down to Dover and I spoke to the second in command. I said, this is a very important trial. We need to know what, how good these drugs are, how well tolerated they are. So he put it on Part 1 orders, which are what soldiers read every day. You really must take your pills during this when we're in Kenya, and if you want to, if you don't like them for any reason, just tell the medics and we'll sort it out. And then I personally went to Bryce Norton at 4 in the morning on a number of occasions, because they went out to Kenya in waves. I personally gave the questionnaires to the troops, and the idea was they had to fill out a questionnaire or they didn't get on the plane. So I got a 100% take-up rate, and it was the same coming back. They wanted to come back. So it was very good. But unfortunately, there was a point in the middle where somebody went out and they did the questionnaire in the middle. Towards the end of the trial, the whole thing collapsed because I was taken off the trial and sent to Bosnia. And also there'd been an unexpected event where a soldier had become psychotic taking Lariam. And later on, another soldier committed suicide from taking Lariam. So it was very unsatisfactory. Anyway, I was no longer in charge of the trial and went to Bosnia, came back, and then the following year I wrote a Cochrane systematic review of this particular drug to try and establish what were its proper properties based on randomized controlled trials, including mine, and that's how I got involved in Cochrane reviews.
Right. You've mentioned there, Dr. Croft, a number of expressions that we're going to become familiar with.
Yes.
in the course of your evidence. Can I just pick up just a few of those?
Of course.
At this stage? Epidemiology,
Yes.
as I understand what you've said, was an aspect of public health medicine, a specific aspect of that. Is that right?
Yes, it's really an aspect of all medicine, and all doctors have an intuitive understanding or sometimes an academic training in epidemiology. And I'll just refer...
Well, you've given a definition of epidemiology.
Yes.
In Appendix 3.
Page 101, I think it is.
It is indeed,
Yes.
page 101. Perhaps you just read that out,
Yes.
so we have that in the note.
So page 101, this is Appendix 3 of my report, my lord. And in Appendix 3, I define key epidemiological concepts, And one of the concepts is the word or the term epidemiology. And the definition I've used here is a fairly standard one. And it's the monitoring and study of factors related to health conditions and the implementation of control measures to prevent disease occurrence. So epidemiology might encompass, often will encompass infectious diseases, but it also extends to non-infectious diseases. So you might study the epidemiology of road traffic accidents, for example, and work out why they're occurring, where they're occurring, and how you might try and mitigate them or prevent them. The word epidemiology, the Greek actually means that which falls down upon us from above. So it's quite a good idea. It's really anything that's unexpected or really unfavorable. We try and work out what it is about it that we can know, and then how we can mitigate or even prevent it.
And I think from what you've said, there are probably many aspects of epidemiology that one has to take into account, but I think possibly two that are of significance would be an understanding and an ability to apply statistics and statistical analysis.
Indeed.
And also, as you say, looking at control measures to prevent disease occurrence.
Yeah.
Now, would control measures also include prevention of further infection through disease?
Yes, so if we were looking at a non-infectious disease, motor vehicle crashes, we'd look at helmets and seatbelts. For infectious diseases, the control measures might be, if it was foodborne transmission, a disease caused by foodborne pathogens, you would try and implement food hygiene measures. If it was a respiratory pathogen, you would look at maybe air filtration or ventilation, as well as maybe more extreme measures. If it was a bloodborne pathogen, you'd make sure that proper sterile techniques were being used, and any blood transfusions were free of pathogens, and so on. So it would be specific to the type of disease and especially the route by which that disease was transmitted. That's really key to mitigating measures for infectious diseases.
Okay. Two other phrases that you've used so far, and I think we can perhaps helpfully find these referred to in Appendix 3. One was randomized controlled trials.
Yes.
Now, I think probably most people who are familiar with medical papers and data will know what a randomized controlled trial is, and probably most people in the general public probably know what a randomized controlled trial, but you've given it a specific definition. It's at page 102 in Appendix 3, and I think if you could just read that out.
Yes, a randomized controlled trial, in brackets RCT. A randomized controlled trial is defined as the gold standard research study in evidence-based medicine, EBM, and in a randomized controlled trial, study participants are assigned to the intervention group or to the control group in a random fashion.
Yes. So if one is taking, for example, a vaccine,
Yes.
you would have a group who had been vaccinated, and there would be a control group who either were not vaccinated or had been given a placebo, as it's frequently
Yes,
termed.
the experimental group, as it's called, the intervention group,
Yes.
receives the vaccine, and the control group might receive a different vaccine.
Yes.
Sometimes it's not ideal to have a different vaccine, or they might receive saline, some inert solution that looks as though they're getting an injection, but isn't a vaccine.
And I think if you go back to page 100 in Appendix 3,
Yes.
you will also find a specific type of random control trial, which is a cluster randomized control trial. Perhaps you
Yes.
just read that out, and if appropriate, just expand on that a little.
Yes, so my lord, in a randomized controlled trial, usually they involve individuals, and like in the two examples I just gave of the soldiers, and the unit of randomization for a trial with individuals is the individual. So you would say you've got so my Grenadier Guards, for example, 330 of them are randomly assigned to the intervention, the drug, and the other 330 were assigned to the other drug. The numbers are never going to be exactly the same, because the randomization process means that the two arms never have exactly the same numbers, but they usually differ by only a few. So that's randomization as it normally occurs. But in complex interventions, you might want to use a different unit of randomization. For example, you can do randomized control trials in schools, where your unit of randomization would be the school itself. So, for example, if you were worried about some aspect of school dinners, for example, you could take all the schools in Scotland and half of them randomize them to this aspect of school dinners you were worried about, and the other half you randomize them to standard school dinners. And then you have a randomized control trial, which is a cluster randomized trial, a cluster randomized control trial, and that is as valid as a individually based randomized control trial. They're more difficult to set up, but they can be set up. And indeed, some occurred during COVID and the lead up to COVID, which we may touch upon later on.
And one other expression that you've used so far, and we will come back to these obviously in some detail, because there are three papers in those that you have prepared for us that have this title, and that is Cochrane Review.
Yes.
Now, again, there is a useful brief expression of what a Cochrane Review is at page 101 of Appendix 3.
Yes.
And perhaps you could just read that, and then bearing in mind that we are going to look at these in some detail in due course, just give an indication of what is a Cochrane Review.
Yes. Evidence from randomized controlled trials is very powerful. We may talk a bit more about that in general terms later.
Yes.
And it's ideal to, or often it's very helpful to combine evidence from a number of randomized controlled trials using a mathematical method that's called meta-analysis. And Cochrane reviews are an approach to doing that, to first of all gathering all the evidence that's available on a particular topic of concern or of interest, and ideally the evidence should be that from randomized controlled trials, and then the individual trials are assessed for their quality, and then they're combined using this method called meta-analysis to produce, in effect, a larger randomized controlled trial where there's a greater degree of confidence in the findings. That's what a Cochrane Review is. They're named after Scottish public health man called Archie Cochrane, who was born about 1920 and went to Cambridge and then worked in England and in Wales. He ended up in Cardiff as an academic, and he was the first really to highlight that there is an enormous wealth of biomedical knowledge. The amount of scientific data is massive, and no clinician, no policymaker can hope really to keep up with all that's necessary. So he conceived the idea of having a sort of central point by which all of that data was being systematically assessed and analysed and then summarised, so that individuals, the individual GP, the individual hospital doctor, didn't have to go through the process of doing it. Archie Cochrane died in about 1986, and his work was very influential, and a number of doctors mainly in England and also Canada, Scotland as well, came together to form the Cochrane collaboration in the early 1990s, and this is what they set out to do. They ambitiously set out to consider every important clinical question, and there are tens of thousands of these, and to gradually and progressively examine them all through systematic review of the evidence for those interventions, and focusing on the potential benefits of the interventions, and also, importantly, the potential harms of the interventions. So the Cochrane collaboration, of which I've been a member since about 1995, but I haven't done any reviews for a few years. But they now produced, I think, about 10,000 reviews. They cover a tremendous number a range of topics. And during COVID, towards the end of the pandemic, an important review came out to do with the physical measures to try and prevent the spread of the virus that causes COVID-19. We might be looking at that later, my lord. And there was also, last year, a review came out. It was a preliminary Cochrane review looking at the efficacy and safety of vaccines to prevent COVID-19. So they're very important, extremely important sources of evidence for us.
Just take 2 points from what you've said.
Yeah.
First of all, you mentioned the expression meta-analysis.
Yes.
I think we can probably make a guess at what that is, but can you tell us from your point of view what it is?
Yes. If you are conducting a study where you end up with some numbers at the end, I think it might be helpful if we went into the typical kind of numbers that you might obtain from a study. You report those numbers, and they will mean something to people who understand the numbers. If you then want to combine the results of that study with a kind of comparable study to get a better more precise estimate as to what it is that the investigators are trying to find, you use this method, which is called meta-analysis, and it's to do with mathematics. It's complicated, and I have to take a lot of it on trust myself. But it's an accepted method of producing more precise numerical estimates of effect, and the effect means whatever it is that the study was trying to show.
Well, on mathematics, I'm afraid you're not going to get any help from me. But the other point that you've perhaps alluded to is, I take it that Cochrane reviews are regularly updated.
They are. It depends really on what the review topic is, because some areas don't generate many new randomized controlled trials, but some areas of medical science are generating randomized controlled trials all the time, and so therefore new evidence comes along that may alter the findings of an existing Cochrane review. So, excuse me. So a Cochrane review, where there's new evidence coming along, would normally be updated every 3 to 5 years, perhaps. But what's very helpful about Cochrane reviews is that there often will come a point where the reviewers say, the evidence for this intervention is so compelling, there's no need to do any more randomized controls. Please stop doing more research, because the evidence is there, and research funds are limited, and it's better if you research something else. And equally, they might say the evidence against this intervention is so compelling that you shouldn't really do any more research. And they can say that with authority, because they have the end point of these reviews is one of quite significant precision.
I think this is something that we will come to
Yes.
in some more detail. But in the documents you've provided us with, one of them you've already referred to, which is the 2023 Jefferson, the principal author,
Yes.
main author, Jefferson Cochrane Review. It's number 9 in the bundle of documents, and that is a Cochrane Review into the title being the physical interventions to interrupt or reduce the spread of respiratory viruses.
Yes.
Now, I think we can see from the date that is post certainly the worst of the pandemic, if I can put it that in those simple terms. But before that, document number 8 in the bundle is Jefferson 2011, with a similar title, Physical Interventions to Interrupt or Reduce the Spread of Respiratory Viruses.
Yes.
So just looking at those two, as I understand it, there was not, between 2011 and 2023, an update of a Cochrane review on the prevention of respiratory viruses.
No, that's true. There wasn't. This particular review, the 2011 review, had been updated several times.
Yes. Yes, I think we can see that it had been updated several times. But I think what is important,
yes,
at least for our purposes in this inquiry, is that the 2023 Jefferson Cochrane review did take into account preventative measures and the lessons learned from those preventative measures as a consequence of the COVID pandemic.
Oh, the updated one, yes. That covered the entire gap from 2011 to 2022, and then they published their essentially further update of their previous update in early 2023.
Right. Yeah, it may seem a little while ago, Doctor, but can we go back to your CV? We may, I think it's probably been useful just to set a number of concepts and references that you will make in context. Your academic qualifications, sir, are at page 83.
Yes.
I think. We can see after a year at university in Madrid, you went to Oxford between 71 and 74.
Yes.
Graduated from Oxford in 74, is that right?
Yes, that was my BA, which was my first degree, which was in English.
Yes. So you diverted off after that.
I did. I was working in children's publishing for a while after that, and I thought it'd be nice to be a doctor. And so in the evenings I was studying A-levels, which I think you call higher, in science. And then in 1977 I applied to various medical schools and was accepted at Guy's Hospital Medical School.
Yeah.
And in fact, it was a course where you could apply directly as an arts graduate or with arts A-levels, and that was quite common in medical schools at the time. It used to be the standard way of entry to medical school. You did classics at school, and you did medicine.
Yes. Yes, I was always told that in order to do law, it's good to have the Latin.
Yeah, oh yes, yeah, sure.
You also say at just to get this clear, at page 84 of
Yes.
your CV, you also obtained a Master of Arts degree from Oxford
Yes,
in March 1984.
Yes. At Oxford and Cambridge, you get a Master of Arts automatically after 21 terms after matriculation. But I didn't get round to picking it up until 1984 when I went in person and got it.
Thank you. Right. As you said, you attended Guy's Medical School between 74 and 84 and obtained your degree in 1984.
Between 78 and 84.
So
Yes.
78 and 84, yes.
Yes, correct.
And you also subsequently obtained a Master's in Community Medicine from the University of London in 1990, is that right?
Yes, that's right. That's when I started my specialist training in public health medicine. And I should have mentioned that the Faculty of Public Health Medicine encourage doctors to work as general doctors in either as GPs or in some specialty, some clinical specialty, for a few years before doing public health medicine.
I see.
Because essentially we're not dealing with patients as individuals, we're dealing with groups of patients. So it's good to have pretty good experience of dealing with patients as individuals. So I didn't start public health training, which I started with that MSc until 1990.
I think we can also see that also from the University of London, you obtained 2 diplomas, one in the medical care of catastrophes,
Yes,
and also in tropical medicine and hygiene, is that right?
correct. Yes.
You, just to complete your academic background, you obtained a doctorate from Portsmouth University in January 2022, quite recently.
Yes.
You've had a long association with the University of Portsmouth. Can you explain that a little?
Yes, I worked in the army as a public health physician for 27 years, and towards the end of my time, I started a doctorate course at Portsmouth University part-time, and this continued, and it went on for quite a long time, 9 years, and during lockdown I was able to complete my thesis. That was part of the, for me, helpful aspect of lockdown, which was otherwise very damaging for me and for everyone. So I put in my thesis, and the title of my PhD thesis was Evaluating the Adverse Effects of Anti-Malaria Drugs, which I've been working on for nearly 25 years. But the PhD came in only towards the end of that time. So part of that thesis, with a PhD thesis, you're supposed to include as part of it 3 or 4 scientific papers that you've published. and they will be discussed in the exam. I had 12 papers that I included, and they covered a range of epidemiology, not just malaria. So I put in my written paper in 2020, and there was a hiatus because the universities were kind of not functioning. But in 2021, I was told I could now have an oral examination on the paper. So this took place in 2021 remotely. And for PhDs, you have 3 examiners who quiz you on your thesis. Normally there's one from the university and 2 external examiners. So I had 3 examiners. It was done remotely. And at the end of it, they can either reject your thesis or accept it or suggest major changes or minor changes. But then I said, no, you can be a PhD. They said you can be a PhD immediately, which was very nice. But do make a few minor changes like typos. And they said it would be helpful if you enlarged a bit on. There was a section where I talked about the need for further research. So they said just write a couple of extra pages for that. But for practical purposes, you can call yourself a PhD from. That was December 2021. And I actually wrote up the bits they asked me to do in January after Christmas and sent it in. And then I got the letter back saying that's fine. And picked up my PhD in person in July 2022. And by then, everything was open, so it was very nice.
You've mentioned now on a couple of occasions
Yes.
an interest in malaria, and we will come to look at some of your papers, but I think we can see in your published papers that you have had over a very considerable number of years an interest in malaria and its treatment. Is that right?
Correct.
Thank you. Just for completion, I think you're also a linguist.
Yes.
And you're a member of the Institute of Linguists, and you're an accredited interpreter in French and Spanish.
Yes.
Can we move on then from your academic experience, Doctor, to your professional experience? And I think in your CV we can see that after a year as a house surgeon physician in Guy's, you then make reference to an engagement, this is at page 85 of your CV, an engagement in the Falklands.
Yes.
And I'm inferring from that that was in connection with your army career.
Yes, I trained in the NHS and paid my own way for most of it. I did get a grant towards the very end, actually. But because I had a first degree already, I had to do the 3 years self-funding. So after qualifying, as a doctor, you become what was called a house physician or house surgeon, and during that time it's called pre-registration appointment. So you're working under supervision. But when you've completed that year, you then become fully registered with the General Medical Council, and you can then do whatever you like to emigrate to America or whatever. And I joined the army then because I'd been in London for 7 years. I wanted a change. So I joined the army on what was called a short service commission, which was 3 years. And I rather liked the army, actually. And I got married during that time. My wife liked the army, so I stayed on. But anyway, so I joined the army in February '86 after finishing my house surgeon job at Guy's Hospital and Lewisham. And then we had a period of 4, I was with about 20 other doctors, one of them from University of Dundee. And we had 4 or 5 months of specific military medicine training and to prepare us for a new role as army doctors. And at the end of that, I got what was called a posting order to go to Germany. This was in the Cold War, so I was sent to the front line up against the Russians. But they diverted me to the Falklands because they'd been told to provide something. So in fact, I didn't go to Germany until the following year. I went to the Falklands for it was 4 months, June till October '86, and worked there. Then I joined my regiment to which I'd been assigned, which was the 1st Regiment Royal Horse Artillery in in Hohne in West Germany.
Right. And really just taking it short, Doctor, you had various appointments, I think in various capacities, in Germany, London, Bosnia, Afghanistan, and the majority of these were as a public health specialist or consultant.
Correct, yes.
Grew into that role,
Correct,
I
yes.
suppose.
Yes, correct. And once I became a public health specialist, from time to time I'd be sent out to the NHS for short secondments, or in one case for 2 months secondment to Birmingham, part of Birmingham Primary Healthcare Trust, and that was just to really to keep the public health skills up, and to help out the NHS perhaps, and just get benefit of what they were doing. But my employer during all of that time was the Army.
Yeah. And I think you ended your career in the Army with 2 stints as a consultant public health physician in the Surgeon General's department in both London and Lichfield.
Yes, I became a consultant in July 1995.
Yes.
After completing, as I was saying, my Part 1 faculty exams and my Part 2 exams, and doing a further exam. And so then I was a consultant for 18 years. So yes, that takes us through to 2013, when I reached the age of the normal retiring age for Army doctors of 60. It's less for non-doctors.
Yeah.
And so I left the Army at that point.
Yeah. What rank were you when you left the Army?
Lieutenant Colonel.
Sure. Now, I think, and we'll look at some of your scientific papers as we go on, but I think a lot of your scientific papers are either directly or indirectly related to interests that you might have had as a public health consultant in the Army.
They are quite Army specific.
Yes.
Of course, that was my employer, and that was
Yes.
they were the kind of tasks I was being set to do.
Yeah. Could I look at some of the other appointments that you've had at page 86? I think we can see that you were a visiting fellow at the Effective Healthcare Research Programme Consortium at the University of Liverpool. Just tell me what that was about.
Yes, the University of Liverpool Tropical Medicine Department had a very close link with the Cochrane Collaboration's infectious diseases branch. So they hosted that, and they provided secretarial support and other support, for example, in locating trials and doing library searches and so on. So for a period of just over a year, I was at that point updating my my systematic review that I'd written in 1996, and which was one of the first Cochrane reviews to come out, and was published in the British Medical Journal at the same time. And the updating process was quite complex, because we broadened the scope of the review, and so I was appointed to this title, because it then gave me use of the library and use of the facilities at Liverpool while I was doing this task, which took about a year. So I was still in the Army, but I had this kind of extra, it was not an honorary appointment as visiting fellow.
And I think also for a number of years you were an honorary lecturer in travel medicine.
Yes.
At De Montfort University in Leicester.
Correct.
And finally, for about, I think, 10 years, you were also the editor-in-chief of Human Parasitic Diseases.
Yes.
Tell us what that is, please.
Yes, the editor-in-chief sounds very grand, but it was really, I was there to really oversee the correct conduct of the publication process and the peer reviewing process that was going on for this journal, Human Parasitic Diseases. It wasn't a paid appointment, it was again an honorific appointment. And my role usually was to act as a kind of final arbiter, where paper had been submitted to the journal for publication, and 2 of the peer reviewers had said, this is wonderful, and 2 had said, this is terrible and should never be published. So the managing director of the company would come to me and say, here's the paper, here's what the reviewers say, what do you think? And so I'd arbitrate like that. And they'd also from time to time say to me, we want to put out a special issue with a call for papers. What are the kind of topics of interest in the field of parasitical diseases? So I'd list topics of interest, and I'd also perhaps from time to time suggest possible peer reviewers for papers. So it wasn't a very onerous task, but it was interesting, and
Right.
It meant I'd often have to read papers that were I know about them, but they were to a depth that I hadn't been familiar with, and I'd have to kind of really try and nut out what it was that was being said, and come to a decision as to whether this was something we'd want to publish in that form or not. In the end, the publishing house that owned Human Parasitical Diseases, which was based in New Zealand, they sold out their titles to Elsevier, which is like a big publishing giant. And so this journal was merged with an existing Elsevier parasitic diseases publication. So it doesn't exist anymore, and I wasn't required, because they already had an editor-in-chief for their new journal.
Again, it's probably a useful interjection, because you've mentioned in relation to your position as editor-in-chief of Human Parasitic Diseases, peer reviewing papers. Now,
Yes.
again, for many of us, this is probably a concept we're all relatively well familiar with, but it perhaps does need a little explanation. So can you just tell us what is peer reviewing for the purposes of publication? How does it proceed? Who is it done by? Really, as much information as you can give us about it.
Yes. Yes, peer reviewing is a term which means that when a scientific paper is put forward to an editor of a journal, generally before the editor makes a decision, he or she will send it out to a number of acknowledged experts in that particular field, and there may be people that the editor knows about, or there may be experts that they find by seeing who else has published in this field. And the peer reviewers, they do it for nothing, and I've done a lot of peer reviewing in my time. They do it for nothing. It's just meant to be part and parcel of what you do if you're a responsible scientist. They'll read the paper. They'll often be told try and do it in a week or so, and they'll often have a checklist that's provided by the editor to say, well, are the methods set up correctly? Are the results reported properly, and so on? Is the statistics sound as far as you can tell? There'll often be a separate statistics peer reviewer, because statistics is quite a specialized area. And then at the very end, you'll be given, usually, this is what we had in my journal, a list of options. Publish as it is, or publish with major revisions, or publish with minor revisions, and you could specify what those are, or don't even think about publishing it but you normally have to give your reasons. So you send that in, and other peer reviewers will be doing the same, and then the editor makes a final decision as to whether or not to publish. And they have to do that, firstly, to guard against research fraud and possible or unintentional errors that might have been made by the investigators that perhaps they weren't aware of. And so to some extent it's protecting the editor's own back. But it acts as a sifting out process, so that really the idea is that the best studies get published quicker in the best journals. That's the idea of it. But the top journals will reject 90% of the papers submitted to them, usually after peer review, because there's just too much science that's being produced all at once to get into the most prestigious journals.
So, can I just ask you, do I take it from what you're saying that you've been on both sides of the peer reviewing exercise, both as a peer reviewer
Yes.
and submitting papers that are subject to peer review.
Of course, yes. I've been exactly. I've had papers peer reviewed, and unfortunately, I think it's unfortunate. Peer reviewers tend to be anonymous. So you don't know who's actually reviewed your paper, and it could be your worst enemy who's reviewed it, and this does happen. So your worst enemy, your rival in your field, could peer review your paper because he's the only other person who knows about this unique topic, and they could just review. They said to the editor, don't publish this, and so there's no real redress against rejection. So I've been in the position of having papers peer reviewed and accepted by the editor, or sometimes not accepted. And I've been a peer reviewer for about a dozen journals, and then I've been at the stage beyond that, where I've been the arbitrator, where peer reviewers have reached an impasse where they can't decide amongst themselves whether to publish or not. So I think I'm familiar with the process.
Thank you. Just moving on to one other appointment. You mentioned that you have been an appraiser of general medical counsel, registered consultants and general practitioners from April 21 to date. This is again, it's page 86 of your CV. Now, I don't wish you to breach any confidences, either personal or professional, but can you just tell us what that role involves?
Yes. About 10 years ago, the General Medical Council, and also I believe the General Nursing Council, introduced the idea of annual appraisals. I'm sorry, nurses don't do annual appraisals, they do 3-yearly revalidation. But doctors were required to do annual appraisals to a certain format, and the format's dictated by a document called Good Medical Practice, which is produced by the General Medical Council. So you have to show during your annual appraisal that you've conformed to the principles of good medical practice, and it's set out in various domains, and that they cover areas such as courtesy to patients, good record keeping, clear handwriting, keeping up with your topic, keeping up with your area, and patient confidentiality and so on. And so that's the background to a doctor's annual appraisal. Everyone has to do it, and then and you have to do it with an appraiser who's also a GMC doctor, and then after 5 years, your responsible body, which is the body that you belong to, that in a way guarantees your professionalism, your competence, will make a recommendation to the GMC. This doctor, Dr. Smith, has undergone 5-yearly appraisals. Also, yes, during that period you have to do what's called 360-degree reflection, which means you get your peers are meant to comment on your performance, patients are meant to comment on your performance, or if, nurses, and that's part of the revalidation process. You're also meant to conduct a quality assessment exercise of your own practice to try and improve your practice. So provided all those criteria are met, the responsible body will make a recommendation as to whether or not you should carry on for another 5 years as a GMC registered doctor. So it's quite sort of bureaucratic, but I think it's good. I think it actually does improve medical practice.
Just again diverting away briefly from the GMC.
Yes.
If we go back to page 82 of your record, of your CV, I think your responsible body for appraisal and revalidation is the Independent Doctors Federation.
Yes, it is now.
So you undergo this process?
Oh, yes, certainly. I undergo it every year, and my appraisal is coming up in October. So there's quite a lot of bureaucracy I've got to go through then, and you'll have to show your appraiser that you've kept up to date with your your faculty normally will have a requirement to do a certain amount of CPD every year. In my case, we're expected to do about 50 hours of continuous professional development of various kinds. But the aim is to do 100 hours. So you show that you've done that and that your faculty has confirmed that. And then they will ask you, have you been, killer question, are there any investigations against you? Are there any complaints against you? And and if there are complaints against you with the GMC, you have to declare them. You can't conceal them because they already know, because if there's a GMC investigation against the doctor, the GMC will notify the doctor's responsible body, and so the appraiser will already know. So if there's an investigation, it's not necessarily it's not the end of the world, because often the investigations don't come to anything, but you have to discuss them with your appraiser, and you reflect on what you might have learned or the background, and then that's recorded. And you also tell them about your general health. I'm happily in the position there has never been any complaint against me to the General Medical Council, and I think I'm right in saying that all General Medical Council investigations are logged and registered in perpetuity. So it's not something that one can really get away from if it should ever occur.
Okay, can we go back to the GMC, please?
Yes.
Can I ask what qualifies you for a role with the GMC as an appraiser?
Actually, I believe any doctor can appraise another doctor, as long as it's done in the correct way, with the recognition of a responsible body. But I myself went on a 3-day training course with the Independent Doctors Federation because they needed some appraisers, and then I did some appraisals after that, based on that training, which very closely followed what I was just mentioning, the good medical practice guidelines. So the appraiser doesn't actually. It's not the appraiser who says at the end, you're fit to go, carry on for another. They just go through the process. It's a responsible body that, on the basis of the 5 successful appraisals, will say to the GMC, right, that this doctor is. We recommend the doctor for revalidation for a further 5 years.
And can I ask again, without involving you in any compromise of confidentiality, can you indicate the areas in which you may have been an appraiser?
As an appraiser, you can appraise anybody in any doctor in any discipline,
Yes.
either a GP or a consultant, because the principles of good medical practice apply to all doctors. So you don't. So let's say you're a psychiatrist, you don't have to be appraised by a psychiatrist. You can be appraised by a GP, and I myself have been appraised in the past by a psychiatrist. Is really good, excellent, best appraisals I've had, and by GPs and by a rheumatologist, and my current appraiser is an occupational physician. So the specialty doesn't matter as long as they follow the format that's approved.
So would I take it from that in order to be an appraiser, you would have to have a certain standing within the profession?
You'd have to be registered with the General Medical Council.
Yes.
Yes, that's what you have to do to be an appraiser. You have to be on. You have, because you're doing this on behalf of the General Medical Council. You have to have a GMC number.
Yeah. And also, would I be right in thinking that you would have to have the quality of independence?
Of course. Yes.
Sure.
And it was good, thank you very much. And so really, the appraiser shouldn't be known to you. It should be somebody you don't know. And after every 3 years, you ought to change your appraiser. I think that's a requirement. So you can't have the same appraiser for 20 years. That wouldn't be appropriate. And the system isn't perfect, and clearly sometimes it breaks down, and doctors are charged for the most heinous crimes correctly, and that's terribly unfortunate, but it's rare, I believe.
Briefly, can I look with you at your postgraduate awards and decorations,
Yes.
which are at pages 87 to 89? And really, again, just taking these relatively briefly, you've had 2 decorations in relation to, specifically in relation to your military career. And I think you received the NATO Medal for Service in Bosnia in 1996, and also the Campaign Medal for Active Service in Afghanistan in 2008.
Yes.
I'm particularly interested in the references, the last reference on page 1989 to the Cochrane Club Award. Obviously, there's a similarity in the name. Could you explain what that was for?
Yes, the year before, so I was given this award in Auckland in New Zealand at the Cochrane Annual Colloquium. That's the big meeting they have every year, which moves around to different Cochrane centres around the world. So that year is in Auckland, and I'm just going to look to see what Cochrane Review has given it for. It was for doing a podcast in relation to 2011. Yeah, I produced a Cochrane Review about the use of helmets. So here we are. So page 93. That's right. Fourth one down. I produced with two co-authors. I produced a Cochrane Review, which was titled "Helmet Therapy" in bracket worms for allergic rhinitis, and we looked at various trials where people suffering from allergic rhinitis were assigned to be given helmet therapy or placebo to try and improve their allergic rhinitis, and we found there was a modest effect in improvement of the hay fever, which is and I produced a podcast. I think I was given an award because it was such a novel area, as considered to be interesting and out of the usual run of Cochrane Reviews, and so it's very nice.
Right. You've also appended to your CV an extensive list of publications,
Yes.
which are divided into what you describe as main scientific publications.
Yeah.
Then there's a section on research letters, which I understand they are what they say they are. They're letters in which are submitted to medical publications relating to areas of research.
Yeah. Yes.
And then you also, there is then a list of books that you've made contributions to, and then a list of national and international presentations. I'll come in a little to look at the list of occasions on which you've been invited to be an expert advisor to official inquiries. But obviously everybody can read the list of your publications and those of which you are associated with. And as I've said earlier, you appear to have an extensive interest and have written extensively on malaria. So again, can you confirm
Yes.
that? Yeah. And again, also a lot of your papers are associated with your time in the military
Yes.
and relate to circumstances you experienced in the military.
Yes.
And I think you've already also made reference to one paper in relation to pregnancy and breastfeeding women who, at that time, their careers came to an end in the military. That's paper number 2 at page 90. And there's another paper, I think, that relates to. I'll just find the reference. Yes, there's a reference at page 91. It's the third paper from the bottom, in which you are a co-author, and it's entitled "Does Military Service Damage Females?" An analysis of medical discharge rates in the British Armed Forces.
Yes.
Can you just tell me what the journal that was published in? I assume it's occupational medicine.
That's right. Yes.
Yes.
Yeah.
And can you just indicate what was the subject matter beyond the title of that paper?
Oh, that's one of the few papers I didn't write entirely myself. I contributed to it, but the lead author there was Squadron Leader Katie Geary, who was my public health trainee, and she had an interest in this. She was doing this as one of her big projects, Katie, and then David Irvin, the second named author, was a civilian epidemiologist who was working with us in the defence in the Surgeon General's Department of the Administrative Defence. So Katie Geary just set out the information she had about medical discharges from the armed forces. This is when somebody joins the armed forces and carries on for a little while, but then has to be sent back to civilian life because they're not medically fit. And it was a concern at the time because the rates of medical discharges were going up, and so she, I think, had been told to look into this particularly and try and draw some conclusions. But I can't actually remember in detail what her conclusions were, but it led on to some other research, which you might be coming on to, Mr. Gale, which is to do with training injuries.
Yes. Okay. Just finally, in relation to your papers, you also presented a paper, this is at page 95, and it's the third from the bottom on page 95, entitled Trends of Post-Deployment Mental Disorders.
Yes.
Can you explain what your contribution to that as a public health consultant would be?
Yes, again, I was reporting on data that was being routinely collected at the time by the Medical Statistics Department in relation to the incidence of mental disorders in troops. They were rising then, and they continued to rise over the next decade. And there are a number of reasons for that, amongst them the fact that there were still many troops who'd served in the Falklands where they'd been exposed to traumatic events, many who'd been in Northern Ireland where they'd been exposed to traumatic events, or again Iraq. So they were the main contributors to the rising trends. And I was simply describing what was being observed without actually, it wasn't based on my own primary research into that area, other than just really summarising what other people were finding and trying to fit that into some kind of pattern, and sharing that information with other NATO colleagues.
Right, I think we can divert from your CV now briefly, Dr. Croft, and could we go back to the very beginning of your statement?
Yes.
And the circumstances of your instruction for this inquiry. And I think at preface page 1, under the heading Scope of Report, you say that this report was commissioned in May 2023 for the Scottish COVID-19 inquiry. The inquiry's letter of instruction is reproduced at Appendix 1. And if you could bring up, please, Appendix 1 so that you can look at it. We just see the terms of that instruction. Now, this was a letter to you from Miss Clements, who's the interim deputy solicitor to the inquiry. It reads, Dear Dr. Croft, as the interim deputy solicitor of the Scottish COVID-19 inquiry, I would be grateful if you would accept this letter as your instruction to utilise your expertise as an independent consultant in public health medicine and provide the inquiry with a written report which will subsequently form the basis of evidence to be given at the inquiry, which is likely to take place in late July 2023, and that's where we are. Yeah. And then there's a passage on the scope of your report, and there's a reference to discussions that you had with Ms. Soper, the co-secretary of the inquiry, and indeed with myself as the co-lead counsel to the inquiry. And after the section that the sentence that ends with my name and co-lead counsel, it continues on the report which the inquiry wishes you. Could you just read that remainder of that paragraph out to us, please?
Yes. The report that the inquiry wishes you to provide is one which will provide the inquiry with a factual narrative detailing the state of accepted scientific knowledge concerning coronavirus and COVID-19, as that knowledge was understood by public health practitioners in the period between late 2019 and the end of 2022.
Would you just go on, please?
In particular, your report will include the evolving state of scientific knowledge around A, the nature of coronavirus and COVID-19 and its pathogenicity, B, the ability or otherwise of masks and other forms of PPE or other measures as recommended to medical, nursing and care practitioners and the public at various stages during the period from late 2019 to the end of 2022 to prevent or restrict transmission of the virus, and C, the utility or otherwise of hand washing, social distancing rules or guidance, social isolation measures or guidance for those at risk and or those infected, COVID-19 specific treatments and vaccines at various stages during the period from late 2019 and the end of 22 to prevent or restrict transmission of the virus.
All right. I think we can leave it there. As is inevitable, there is a word used in that section which perhaps it is useful to get your definition of at this stage, or your understanding of, and that is pathogenicity.
Oh yes.
Now, just before we do that, there is a definition within your Appendix 3 at page 102
Yes.
of pathogen.
Yes.
Yes. Now, the extent to which, maybe my simplistic approach to matters, but the extent to which pathogen and pathogenicity are related may exist in my mind, but perhaps not in yours. So perhaps you could just explain, first of all, what a pathogen is.
Yes.
And then what you understand by pathogenicity.
Yes. A pathogen, as I've explained, my lord, is a microorganism. So it's a small organism that I was trying to avoid the word living because, of course, viruses aren't living. It's a very small organism that causes infection, and pathogens are generally divided into fungi, like Candida, for example, Aspergillus, bacteria, we know about those, and viruses, and also protozoa such as malaria parasite, schistosomal parasites. So pathogenicity is the term that describes how grave a threat are they to the potential host, the humans or the animal hosts, and that is an umbrella term that will include their transmissibility and also their lethality or otherwise. So it's a sort of rather broad term that in real life context you'd break down into what exactly it is that what aspect of their disease causing ability is the one that you're interested in.
Okay, thank you. Now, going back to your instruction, obviously by accepting that instruction, you accepted that you require to have a sufficient degree of expertise from the standpoint of a consultant in public health medicine, as you say, in the pathogenicity of COVID-19 and coronaviruses in general. I'd like to just investigate with you briefly, Doctor, where that knowledge and expertise has come from. You've said in your disclaimer at preface page 1 of your report that at the bottom of the first full paragraph that you have acted as an advisor in a medico-legal capacity for both sides in a number of legal actions relating to COVID-19.
Yes.
Now again, conscious of confidentiality here, but could you give us some indication of what that has involved?
Yes, if you're instructed in a medical legal action, by either party or jointly instructed, you, as an expert, will write a report addressed to the court. And it's important that you are independent as an expert. So perhaps the wording there might have been phrased slightly differently. So the focus of whatever advice you're giving is in fact the judge or the court as a body. And this I was approached a number of times during 2021 onwards to give advice of this kind for civil actions, and took on those instructions. And there were other advisory roles that I'd taken on as well, which we may come to, which where I acted as an independent advisor to, shall we say, established bodies.
And do I take it from, by accepting instructions in those situations,
Yes, yeah.
you require to inform yourself of, in general,
Yes.
as we're talking about COVID-19 and coronaviruses in general,
Yes.
of the pathogenicity of those?
Of course, yeah. In fact, the first approaches I had were in 2020. I had some very early approaches, and those I declined because I said, well, the knowledge is still evolving, and I wouldn't be in a position really to assist you from helpfully, and I might have to revise my position as time went on. So I didn't accept instructions, though I did have some approaches, really until middle of 2021, and by then I'd also, we might come on to this, been advising the General Medical Council on some general matters to do with COVID. I'd also advised a big insurance company. The insurance companies were caught out by COVID-19, and they had a lot of business interruption claims, which I believe is possibly going to be part of this inquiry. And one of the big insurance companies came to me, I don't know how they got my name, and they said, could you do a horizon scanning exercise for us of all the infectious diseases that there are, and which of them might be the next, another, might become a pandemic in the future. So that was quite a challenge, and they wanted it in 2 weeks, of course, but it took me about a month. So that was helpful in terms of crystallizing my thoughts and my knowledge as to every infectious disease. And I came up with a list of about 12. Top of the list was influenza. I thought, well, influenza is always mutating and potentially could cause a serious epidemic any time. And I had another, that was amber to red. I had about a 10 or 12 amber and infections that potentially could cause serious epidemics. One of them was monkeypox. That was interesting. Before it became a problem, and then the rest of the infections, I said these are not ever going to cause a pandemic because they're not pathogenic enough. Their pathogenicity is not sufficient that they'll ever be a major problem. But they'll cause minor problems, but there won't be business interruptions on a large scale.
It's approaching 11:30, which
So
I
just
think should
take one more matter, my lord, and it'll be fairly brief. Dr. Croft, just to conclude this section and conclude this session, you have provided us with obviously an extensive list of your medical publications. Can we go to page 93, please?
Yes.
And can we look at the last two articles of which you are a co-author with Dr. Mawson and Dr. Gonzalez Fernandez?
Yes.
And there are two there. The first is Clues to Understanding the Pathogenesis of Coronavirus Infection, and then we give it the COVID-19 SARS-CoV abbreviation. And then the second is, again with the same two co-authors, liver damage and exposure to toxic concentrations of endogenous retinoids in the pathogenesis of COVID-19. Can you briefly tell us what those were about, beyond the terms that we can read there?
Yes. These two papers, which are publicly available, they were The first one was published in BMJ Online quite early on in the COVID pandemic. I think it was March 2020. And the second paper was published in a peer-reviewed journal, Viral Immunology, in 2021. But they dealt with a common theme, and that was the proposal that I and my co-authors were putting forward, that one aspect of COVID-19 that was puzzling then and still is puzzling to some extent could be explained if we consider the disease as being in part a assault on the liver, a virological assault on the liver, such that the liver, which stores retinoids, which are vitamin A precursors, normally in a safe form, liver becomes inflamed, and the retinoids, which potentially are toxic, spill into the general circulation and then cause distant systemic effects throughout the body. And we simply reviewed the biochemical and clinical literature to explain how we arose at this hypothesis, and we set out various strategies by which the hypothesis could be potentially tested.
First of your papers, I think, was published in the BMJ, is that right?
It's the BMJ Online, yes. Because of the peer-reviewed process that we were talking about earlier, which is quite long-winded and laborious, many journals now have an online section where they'll publish papers more quickly. They're still subjected to peer review, but that was where that was published. Yeah.
And the second paper is in, I presume, a publication called Viral Immunology?
Yes.
Yeah, where's that published?
I think it's published in America. Okay. It's a hard copy paper, but there was also as is often the case now, there was a preprint electronically a few weeks before it became hard copy, but again, a peer-reviewed journal.
So, against that background, Dr. Croft, and going back to the terms of your instruction,
yes,
are you satisfied that you have the requisite degree of expertise to inform this inquiry in the context of what you've been asked to advise on?
Yes, I have. I set out my qualifications, frankly, at the time I was approached, and there was a period of consideration, and then the inquiry team came back to me and appointed me, and I do feel I have those qualities. The main quality I feel I have, which is important, is the independence from any lobbyists or factions. And I wasn't giving advice formally during the pandemic to any government bodies or commercial organisations. So really, like other people, I was really an observer of what was going on, but I hope an educated observer and a self-educated observer. So I now come to the inquiry from that standpoint as if you like, a qualified public health physician who experienced and studied what was happening and coming to explain what the general scientific background was to the COVID-19 pandemic.
Right, thank you very much, Dr. Croft, my lord. Perhaps that's a useful point to...
It is indeed. Thank you very much indeed. Very good, ladies and gentlemen. We'll have a break now for 20 minutes, please, and we're actually a minute slow. I apologise. If you could be back at 11:51. Thank you.
Yeah.
Good, good. Let's get everyone in. Right. Start again, but before we start, I'm terribly sorry, but I have an apology to make. I have been informed that I made a mistake in my brief opening remarks. I said that the preliminary hearing on the 28th and 29th was in Meadowbank Stadium. I cannot imagine how I made that mistake. I genuinely can't imagine. I've never been in Meadowbank Stadium in my life. It really is in Murrayfield, where I have been on several occasions, not in a team, I should say, simply to observe. So it is, the preliminary hearing is in Murrayfield Stadium. My apologies. Yes, Mr. Gale.
Thank you, my lord. Dr. Croft, having looked at these matters in your background and your qualifications before the break, there is one matter that I'd like to raise with you before we go into the substance of your report. You have been made aware that your engagement as a scene setter in this inquiry has been the subject of some recent comment in the press. And can I first of all refer you to an article which appeared some 2 weeks ago, and I think you've seen a copy of this. I don't need to have it in front of you, but if I can just read some passages from it for your comment. The article is in these terms, or contains these terms. Quote, a doctor commissioned as an expert witness for Scotland's COVID-19 inquiry claimed just 4 years ago that routine childhood vaccinations, quote, could be contributing to increasing rates of autism. Then it is said that and again I'm quoting from the press report, medics have expressed concern that Dr. Croft was still referencing the vaccine link claim, which has been widely debunked and led to its originator being struck off. And I think that's a reference to Dr. Andrew Wakefield, who has been struck up.
I presume so, yes.
The article goes on to say that a recent paper by Dr. Croft, published in 2019, entitled Rubella Virus Infection, the Congenital Rubella Syndrome and the Link to Autism, includes claims that rapid increases in autism coincided with the expansion of the vaccination schedule. And it goes on. 2 more papers published by Dr. Croft and co-author Anthony Mawson from Jackson State University in the USA also included claims about an increased risk of autism in vaccinated children. Claims of a link between the MMR vaccine and autism were initially promoted by Andrew Wakefield, a doctor who was subsequently found guilty of fraud and serious professional misconduct. Wakefield was struck off the medical register by the General Medical Council in 2010. So that's really the context that I'd like to ask you some questions. Could we go to your list of papers? And I think we can see on page 93 of your CV that the paper that is in fact referred to in the press article is the 5th article from the bottom of that particular section, and it is, as you say, rubella virus, or as is said, rubella virus, the congenital rubella syndrome, and the link to autism.
Yes.
That appears to have been published in something called the IJERPH. What's that publication?
Yes, I have a copy of the paper here.
Yes.
And that stands for the International Journal of Environmental Research and Public Health, 2019.
Is that an American journal?
I don't know whether it's American or not. It's not clear from the...
Do you know what...
Oh, I beg pardon. Licensee MDPI Basel, Switzerland. So it seems to be a Swiss journal.
And does that have so far as you're aware, any particular status in the field of public medicine?
I believe it has, yes. It's a peer-reviewed journal. It's available. The publications of the journal are available online, which is always a good thing because it means that they're being transparent in what they publish. My own journal, Human Parasitology, was one of the first of online journals in this field. So it's one with credibility and authority.
Mm-hmm. Right. Now, can you just tell us in as brief terms as is possible what that article was about?
It was on the same lines. It was developing the same theme, exploring the same theme that I've brought up earlier in regard to my 2 coronavirus articles. It might be best if I read the abstract or part of the abstract. Would that be all right?
That would be very helpful, and yes, if you would.
And that way I couldn't be said to be misremembering it or getting key.
No, that would be very helpful.
Yeah. So I happen to have it here. I don't carry around with me all the time, but I've got it here because I thought I might be asked about it. So the article is called Rubella Virus Infection, the Congenital Rubella Syndrome, and the Link to Autism. And the authors are Anthony R. Mawson and Ashley M. Croft. And the abstract's quite short, it's about half a page, but I'll read it all. If there's anything that you wanted clarifying, I'd be happy to do so. So here's it. And the paper, by the way, it's very long. It's 28 pages, and there are 198 citations, so it's not an easy read, even for me. But the abstract is short.
Before you do, Doctor, was that paper peer-reviewed?
Of course, yes, certainly, yeah.
Please continue.
Okay. So abstract. Rubella is a systemic infection that is usually mild. It can, however, cause severe birth defects known as the congenital rubella syndrome when infection occurs early in pregnancy. I should say at this point I have perhaps a conflict here in that my own brother, my youngest brother, had congenital rubella syndrome. He was born in 1963, and he must have acquired rubella in utero from my mother in 1962 when she was carrying him. So he was born with this syndrome, which I'll go on to discuss. And he had some of the disabilities that we talk about in this paper.
I mean, I don't wish to pray into your personal background, family background.
Sadly,
could you just tell us what the symptoms that your brother had?
Right. He had deafness, and he had locomotive problems, so he was in and out of orthopedic hospitals as a child. And with hindsight, he's now dead. He had many endearing qualities, but he probably had a degree of autism, I think, because he didn't go to university, went to school and got some O-levels. He didn't ever marry, and he didn't hold down a job for any length of time. Towards the end of his life, he was effectively the carer to my parents, who both predeceased him. So that was his case. And so
sorry, I've interrupted you. Carry on, please.
So this is an as many as 8 to 13% of children with congenital rubella syndrome developed autism during the rubella epidemic of the 1960s, compared to the background rate of about 1 new case of autism per 5,000 children. Rubella infection and congenital rubella syndrome are now rare, and that's because of vaccination, which is good, in the US and in Europe due to widespread vaccination. However, autism rates have risen dramatically in recent decades to about 3% of children today, with many cases appearing after a period of normal development. This is called regressive autism. Evidence is reviewed here in this paper, suggesting that the signs and symptoms of rubella may be due to alterations in the hepatic metabolism of vitamin A retinoids, and that's what I and my co-authors were talking about also with regard to coronavirus, precipitated by the acute phase of the infection. The infection, that's to say rubella, causes mild liver dysfunction and the spillage of stored vitamin A compounds into the circulation, resulting in an endogenous form of hypervitaminosis A. Given that vitamin A is a known teratogen, that means it causes fetal malformations, can cause fetal malformations under certain conditions, it is suggested that rubella infection occurring in the early weeks of pregnancy causes congenital rubella syndrome through maternal liver dysfunction and exposure of the developing fetus to excessive vitamin A. That's the basis of our hypothesis. On this view, the multiple manifestations of congenital rubella syndrome and associated autism represent endogenous forms of hypervitaminosis A. And we further propose that regressive autism results primarily from postnatal influences of a liver-damaging nature and exposure to excess vitamin A, inducing CRS-like features as a function of vitamin A toxicity, but without the associated dysmorphogenesis. Dysmorphogenesis means the kind of physical abnormalities that occur. And then a number of environmental factors are discussed in this paper that plausibly may be candidates for this role, and suggestions are offered for testing the model. The model also suggests a number of measures that may be effective both in reducing the risk of fetal congenital rubella syndrome in women who acquire rubella in their first trimester, and in reversing or minimizing regressive autism among children in whom the diagnosis is suspected or confirmed. So that's the end of the abstract.
Thank you. Now, you mentioned in a connection with that article the word hypothesis.
Yes.
I think you've discussed in discussions that we've had.
Yes.
The concept of a hypothesis paper.
Yeah.
Can you just explain what that is, again, for those of us who aren't as familiar with these papers as you are?
Yes. Hypothesis, again, is a Greek word. It means an idea, an abstract idea that potentially can be tested experimentally or through other laboratory methods, and may or may not turn out to be correct, or part of it may turn out to be correct. And it's a very common sort of paper in medical science. There are journals, entire journals that are called Journal of Medical Hypothesis, and in those journals, scientists will put forward ideas, often of a revolutionary nature, and often wrong, in fact. But nevertheless, they explore various ways by which observable medical or physiological events plausibly could be explained biochemically or through the what's known about the normal bodily functions. So it's a kind of blue skies thinking sort of paper, which is rather long, but we we had to, or we as would be usual with a hypothesis paper, explain every link in the reasoning through reference to existing research that would support the hypothesis. And it's customary it's normal with a hypothesis paper to end by saying this is a hypothesis and this is how it could be tested, and if it was tested and found to be true, this would be the implications for clinical practice.
Mm-hmm. Now, looking back to what I quoted to you from the newspaper article, on one reading,
yes,
there may appear to be within that article a suggestion that you are a fellow traveller of Dr. Wakefield in relation to, as it said, his widely debunked theory, which led to his being struck off. Are you?
Not at all. No, I've never met Andrew Wakefield, who was a gastroenterologist, and I don't. A theory I accept has been debunked and has no credence.
Yeah. Well, can I just pause again? Can I go back to page 90 of your CV?
Yes.
Because I think you've written on rubella before.
Yes.
And I think if we look just about halfway down,
Yeah.
you are the co-author with Adams and Winfield and Richards. Again, obviously, a paper written with your military experience,
Yes.
called An Outbreak of Rubella in British Troops in Bosnia.
Yeah.
And I assume that's epidemiological infection. So was that, again, is that another journal?
Epidemiology and infection.
And infection.
Yes.
Yep. Can you just give us a little background to that?
Yes. Again, I got the paper here, but in 1996, the year before, I was in Bosnia, having been sent there at very short notice, and I was there for about 7 months. In April of that year, it was a soldier, he was in the Army Air Corps, developed rubella, and this was before, no, I'm sorry, there was MMR vaccination at the time. So he developed rubella. He obviously hadn't been immunized against rubella at any time because he was 24, I think. And this was of grave concern because the period of deployment for the army was usually 6 months, and in the middle of it you'd go back to wherever you came from, Germany or Britain, to be with your spouse or girlfriend. And potentially, if soldiers were acquiring rubella in Bosnia through living in close confined quarters as they were, then there was a potential for them to go back and infect their spouse or partner, who might have been in the early stages of pregnancy, and then she would then potentially be at risk of congenital rubella syndrome.
Yes.
Had she not been vaccinated against rubella, that was the key thing. And that had in fact been a case like this in the German army, where a German soldier had gone back, and exactly that had happened. I think the spouse there had been vaccinated, but she hadn't mounted an immune response, so they had a second child who had congenital rubella syndrome. So this was a matter of concern. So the paper just describes what mitigation measures we took as I was an epidemiologist, and I had to go around the various sort of camps where the Army Air Corps were. We anticipated there would be more cases coming up, and we tried to do a proactive case finding of the cases, and then isolate them in Bosnia until their rubella had cleared up before allowing them to go back home. And we made recommendations for the future as to how to prevent this possible scenario of soldiers acquiring rubella on deployment or on exercise and then going back and infecting their spouses.
Yes.
One of the recommendations including MMR for all troops,
Yes.
or MMR for all recruits, regardless of previous vaccination status. And that in fact, is the very last phrase of the sentence we say. And in fact, the Canadian forces were doing that at this time. All of their recruits, men and women, were all given MMR, even really to protect against congenital rubella syndrome. MMR stands for measles, mumps, and rubella. And even though for adults it's a mild condition, the danger is if the a mother develops the condition in the first trimester of pregnancy. So our last sentence in this paper, Adams and Croft et al., alternatively, military planners could choose to act now by adopting the Canadian strategy of administering MMR vaccine to all recruits, regardless of any history of previous vaccination.
Is that approach that you've referred to in your 1997 paper,
Yes.
is that an approach that you repeated in your most recent paper that has been referenced in the press article?
The general idea of the liver being damaged by external factors and then spilling over the retinoids into the circulation was at the heart of the papers, but
Yes.
the recent papers didn't mention vaccination as far as I can recall.
Did you, in fact, looking at what you actually said in that article, in that paper,
Yeah.
that the proven primary prevention strategy for congenital rubella syndrome is and will continue to be
Yes.
the vaccination of young women?
Yes, we did say that, and that's obviously correct.
All right. Can we move on, Doctor? And can we go to, finally, you'll be pleased to know, the substance of your
Okay.
report. We go to page 2 at part 1 of your report, and this is headed Evidence-Based Medicine. We'll look at this in a little more detail, but as a principle, is this a principle which you as a public health physician and an epidemiologist regard as particularly significant?
Yes, evidence-based medicine is the underlying philosophy, operating principle of medical practice throughout the world.
And I think within your report, you begin with a discussion of evidence-based medicine, and then you go on to certain aspects of evidence-based
Yes.
medicine. So can I just ask you to read through, just to begin with, section 1.1, please?
Yes. Would you like me to read the whole section?
Yes, if you
Oh,
would.
yes, yes. So section 1.1, and of course I'm citing from standard textbooks.
Yes.
So none of this is my own opinion. I'm simply setting the scene for the inquiry, and I'm conveying the accepted, undisputed principles of evidence-based medicine as understood everywhere. So evidence-based medicine, EBM, derives from the understanding that there exists a hierarchy of scientific evidence. All clinical and medical policy decisions should be based on the best available research evidence. And there's a reference to very short paper by Torpy, 1 page. Contrary to popular belief, not all scientific evidence is of equal merit. Many scientific studies are prone to bias. For example, commercial bias. Bias means sort of incorrect influences coming to bear on the results, which might transform those results in a negative way. That's what bias is in a nutshell. Some scientific evidence is more reliable than other evidence. Many studies, and perhaps the majority, incorporate findings that are false. And there's another reference there. EBM, evidence-based medicine, denotes the principle now accepted by all modern medical practitioners that clinical practice and health policy decisions should be informed by high-quality research into the benefits and harms of healthcare interventions rather than be informed by low-quality studies, theoretical speculation, expert committee reports, or anecdote. While the concept of EBM is simple, an obstacle to its implementation in clinical practice is the uncontrolled explosion that has occurred in scientific data. Over 30,000 biomedical journals are currently in circulation, and over 17,000 biomedical books are published annually. And as long ago as 1992, it was calculated that a physician would have to read 11 scientific articles per day to maintain their scientific currency. The challenge is now exponentially greater. Just as an aside, I understand during the COVID pandemic, 2 million scientific articles were written about COVID, and no one could read 2 million scientific articles. So we have to focus on the ones that are the most credible, give the most the best results, the most
Can we
reliable
just
results.
pause there?
Yes.
And look at two of the papers that you referred to? Can we look at Torpy,
Yes.
which is paper number 20 in the bundle, and it's at page 950. I think this is a single page
Yes.
from a publication called, assuming one takes the letters together, JAMA, a patient page. Is that correct?
Yes, JAMA is the Journal of the American Medical Association, and it's the number 2 most prestigious journal in the United States.
Okay. And this
New
is,
England Journal of Medicine being the
Yes, quite right, yes. The New England Journal of Medicine they resisted evidence-based medicine for a few years, funnily enough, but they're now on board.
right. And again, if we can just look at what's said there, I think we can see the author is Dr. Janet Torpy,
Yes.
and interestingly, perhaps in the block on the right-hand side of that page, there is a statement for more information, and the second of those is the Cochrane collaboration.
Yes. Yeah.
Also, I think we can tell, perhaps from the wording of what's on that page, is directed towards practitioners
Yes.
largely.
Well, JAMA at that time, recently they've stopped, unfortunately, but towards the end of the journal comes out every week, and the last few pages there would be a page that would be for your patients, and it would talk about prostate cancer or pneumonia or whatever it was, and the idea was that you would keep these in a file on your desk, and if the patient came in who had prostate cancer, you'd give them this information page, and there are websites there they could follow. So it was primarily directed to patients, but the initial reader would be doctors.
And hence the red stamp at the bottom of the page, JAMA, copy for your patients.
Yes. Yeah.
Would you just read through the first paragraph and then the second paragraph of looking for evidence? So we just have that in the notes.
Looking for evidence.
No, sorry, if start at the beginning.
Oh.
Under the block heading evidence-based medicine in the 1990s. If you just read
Yes.
that paragraph and then the next paragraph of looking for evidence.
Of course. In the 1990s, excuse me, evidence-based medicine, which is in bold print, emerged as a way to improve and evaluate patient care. It involves combining the best research evidence with the patient's values, very important, to make decisions about medical care. Looking at all available medical studies and literature that pertain to an individual patient or a group of patients helps doctors to properly diagnose illnesses, to choose the best testing plan, and to select the best treatments and methods of disease prevention. Using evidence-based medicine techniques for large groups of patients with the same illness, doctors can develop practice guidelines for evaluation and treatment of particular conditions. And in addition to improving treatment, such guidelines can help individual physicians and institutions to measure their performance and identify areas for further study and improvement. And then it says this article is about the importance of using evidence-based medicine to develop practice guidelines. And there seems to be a condensation of a larger article published a few years earlier in JAMA. In 2006, this is distilled into one page.
And then the next paragraph.
Next one, so it's looking for evidence in the medical literature. It talks about, so it's a systematic reviews of the medical literature. Large randomized controlled trials, in brackets, the best way to assess the efficacy of a treatment, and large prospective studies, followed up over time, are types of research published in the medical literature that can be helpful in providing evidence about tests and treatments. Reports of the experiences of individual patients or small groups usually provide less reliable evidence, although they may provide important clues about possible adverse effects of treatments. And using evidence-based medicine, practice guidelines developed using evidence-based medicine have helped to reduce mortality, which means the chance of dying from heart attacks. Evidence-based medicine guidelines have also improved care for persons with diabetes and other common medical problems. Evidence-based medicine does not replace physicians' judgment based on clinical experience. Any recommendations taken from evidence-based medicine must be applied by a physician to the unique situation of an individual patient. Sometimes there is no reliable research evidence to guide decision-making, and some conditions are rare enough that there is no way to do large studies.
I think I can stop you there, Doctor. Just one phrase that I think we can see there and which we haven't, I don't think, looked at a definition of is systematic review. I think you'll find a definition of that in your Appendix 3 at page 103.
Yes.
And I think, so if you're looking at it, it's a type of scientific study which summarizes the existing research in a particular area in a comprehensive and impartial way known as evidence synthesis or meta-analysis.
Yes.
Right. Passing on from the reference to Torpy, could we go to the reference to the paper by Ioannidis, which is number 10 in the bundle. I'm sorry. And that's at pages 806 and 807. Actually, it begins, I'm sorry, at page 802. It's under the headline, we'll put it that way, why most published research findings are false, which might send most people into a spiral of concern. Can you just explain what I think it's now Professor Ioannidis, who I think is now attached to Stanford University in the States.
Yes.
I think at the time of writing he was attached to Tufts New England Medical Center. You'll find that in the footnote on the first page. Could you just read out the summary, please?
Yes. This is a summary of Professor John Ioannidis' paper, and he says, there is increasing concern that most current published research findings are false. The probability that a research claim is true may depend on study power, essentially means the size of the study, and bias, we mentioned bias, the number of other studies on the same question, and importantly, the ratio of true to no relationships among the relationships probed in each scientific field. In this framework, a research finding is less likely to be true when the studies conducted in a field are smaller, when effect sizes are smaller, when there is a greater number and lesser pre-selection of tested relationships, where there is greater flexibility in designs, definitions, outcomes, and analytical modes, when there is greater financial and other interest and prejudice, and when more teams are involved in a scientific field in chase of statistical significance. Simulations show that for most study designs and settings, it is more likely for a research claim to be false than true. Moreover, for many current scientific fields, claimed research findings may often be simply accurate measures of the prevailing bias. In this essay, I discuss the implications of these problems for the conduct and interpretation of research.
So what do you take from that?
Sorry. You happen to know what Professor Iredis' academic background is?
Oh, well,
statistician?
he's an epidemiologist.
He's an epidemiologist, is he?
Yeah.
Oh,
Or I
sorry.
presume he is, because he writes from the Department of Hygiene and Epidemiology at the University of Ioannina, Greece, and then later on he's moved to the United States.
Sorry to interrupt you.
Dr. Croft, what do you take from that?
Well, of course, this needs to be interpreted carefully, because he's not saying research mustn't be done. He's focusing really on pure biomedical research, which is exploring entirely new areas and new concepts, and he makes that clear further on. And further on in the paper, he does talk about randomized controlled trials as being the type of research that is most likely to yield accurate results. But it's really pure and investigative research that is the real focus of what he's exploring there. And this was written when sort of molecular medicine was in its infancy, and the idea of that is you explore thousands or millions of hypotheses connecting a particular gene to a particular disease or a particular aspect of disease. And essentially what he's saying is that if you're exploring on a massive scale, an industrial scale, you will find apparent associations that are actually not true, but they've just arisen by chance. This is key message, as I understand it.
And I think if you go to pages 806 and 807 of that document, I think we can see on the right-hand column of 806 a section headed, "How can we improve the situation?"
Yes.
And perhaps you would just read perhaps read until I ask you to stop.
Okay.
It's really the best thing.
Right. How can we improve the situation? Is it unavoidable that most research findings are false, or can we improve the situation? A major problem is that it is impossible to know with 100% certainty what the truth is in any research question. In this regard, the pure gold standard is unattainable. However, there are several approaches to improve the post-study probability. That's a mathematical concept he discusses earlier. So better powered evidence, for example, large studies or low bias meta-analyses, may help as it comes closer to the unknown gold standard. However, large studies may still have biases, and these should be acknowledged and avoided. Moreover, large-scale evidence is impossible to obtain for all of the millions and trillions of research questions posed in current research. Large-scale evidence should be targeted for research questions where the pre-study probability is already considerably high, so that a significant research finding will lead to a post-test probability that would be considered quite definitive. Large-scale evidence is also particularly indicated when it can test major concepts rather than narrow specific questions.
Can I just stop you there,
Yes.
Doctor, and then can I ask you to read on from at the bottom of that column, the paragraph that begins second.
So second, most research questions are addressed by many teams, and it is misleading to emphasize the statistically significant findings of any single team. What matters is the totality of the evidence. Diminishing bias through enhanced research standards and curtailing of prejudices may also help.
Can I stop you there? I think that's probably all I need to ask you
Yes.
there, unless there's anything further that you would wish to draw to our attention.
Just very bottom of that section, he says, in other fields, the principles of developing and adhering to a protocol could be more widely borrowed from randomized controlled trials. And randomized controlled trials, you normally define what you're going to do before you do it, and you don't start changing what it is you're measuring because of what's emerging, and that's part of the rigor of
So
randomized
the
control.
idea is to have a defined protocol before you start.
Precisely, yeah, and not move the goalposts as you proceed.
Exactly, yeah.
Yeah.
Right, thank you for that. Can we go back now to your statement, to your report, and could go to the top of page 3 and paragraph 1.2, and would you read on there? There is in that page a table taken from a standard textbook for medical students, which is referenced at the bottom. I think it's the yes, it's the bottom, good medical practice textbook, and we'll look at that table perhaps in some detail in a moment. But if you just read through what you say in 1.2.
Just wait for the screen to change. Oh, can I start reading? 1.2. What are systematic reviews? Thank you. A pragmatic solution is a systematic review, also known as an evidence synthesis or meta-analysis. Systematic reviews are a relatively new form of research. Their aim is to present a balanced and impartial summary of the existing research, enabling decisions on effectiveness to be based on all relevant studies of adequate quality. The systematic review has established itself at the highest level of evidence in the evidence-based medicine hierarchy because it summarizes the available evidence on a particular topic in a comprehensive and up-to-date manner. Properly conducted systematic reviews constitute level 1A evidence. The bottom rung in the EBM hierarchy is level 4 evidence obtained from expert committees, authoritative opinions, and the like. And this is demonstrated in the table below, which is from a standard textbook for medical students.
Can we just look at that table? As you say in your text, the gold standard is 1A, and we see that as evidence obtained from meta-analysis of randomized clinical trials.
Yes.
And there are then various intermediate standards, if I can put it that way,
Yes.
down to level 4, which is, as you've said, evidence obtained from expert committee reports or opinions and or clinical experiences of respected authorities. Now, that might seem slightly counterintuitive, that with those qualifications,
Yes.
expert committee reports, clinical experiences of respected authorities might suggest that they are worthy of a higher ranking than the lowest ranking that is given in that category. Can you explain why that is?
Well, it's a paradox because often the randomized control trial might be being done by some junior registrar, and is producing a surprising result that the respected authorities, the senior consultants, may choose to disagree with. But the point of the hierarchy is that the traditional way of developing medical decisions was often in a hospital setting, for example, the senior consultants to sit around and agree between themselves as to what was the best surgical approach to appendicitis or the best antibiotic to give for osteomyelitis, shall we say. And that kind of approach, and by the way, it's sometimes called in the medical literature the GOBSAT approach. GOBSAT, G-O-B-S-A-T, means good old boys sitting around a table, and it's a bit
Probably a relief it wasn't something else.
but it is a recognized study, and it's obviously it sounds, they must know what they're talking about because they're professors and they're senior consultants. But in reality, biases can creep in, not only of a financial nature, but of just a chance nature. The senior professor might just happen to have used a particular antibiotic on 5 not very sick patients because he didn't get the very sick patients. He gave them to the juniors, and so this antibiotic just worked well for him, but that was chance. So this is what the concept of evidence-based medicine is trying to disentangle the authoritative opinions that come from experience, but are liable, often very strongly liable to be influenced by factors of bias coming from various directions.
By according that the lowest level in that table,
Yes.
is that suggestive that one ignores it?
No, when there is no good quality level 1A or level 1B evidence, or level 2 or 3 of it, that would be a reasonable starting point. But at the same time, it would be necessary to qualify very carefully any interpretations that one could put on the weight of evidence that's coming from that kind of source. It would need to be managed in a very prudent way with a lot of caveats.
And those levels are then translated into grades of recommendation at the bottom of the table.
Yes, and
which
now
simply follow
yes.
The levels of evidence themselves.
That's right. And nowadays, with clinical guidelines, of which there's a vast number, the best guidelines will say if a patient presents with these series of symptoms, consider doing this test, and then it'll put in brackets grade A or grade B, and that'll indicate the kind of strength of the recommendation based on this hierarchy, and so therefore it's being explicit about the nature of the advice that's being given to those who will be reading the guidelines. That's often called the grade approach to evidence. The two terms are interchangeable.
Right, can we pass on to page 4 and paragraph 1.3, which is in relation to randomized controlled trials. Now, to a certain extent, you've looked at this a little we've looked at this a little in what you've already been telling us, but just so that we, again, have it in the note, can you read through 1.3, please?
1.3, what are randomized controlled trials? Systematic reviews seek evidence of benefit from randomized controlled trials, RCTs. In an RCT, participants are allocated randomly either to the treatment or intervention of interest, or to the existing standard treatment, or to a placebo. The purpose of randomization in randomized controlled trials is to minimize bias and confounding. In order to minimize patient bias, the participants are unaware of their treatment allocation, and this is termed a single-blind RCT. And some of the vaccine trials look at single-blind RCTs because the doctors knew what they were giving. So in order to minimize doctor bias, treatment allocations are also withheld from the investigators, and this is then termed a double-blind RCT. To recruit sufficient numbers of patients and to examine the effects of treatments in different settings, it may be necessary to conduct the trial at several locations, and this is termed a multi-center RCT, or sometimes it's called an international RCT. To determine the reliability of a particular randomized controlled trial, a number of features in the study design need to be assessed. To ensure there is no selection bias, the process of randomization must be seen to be robust. So it's easy for authors to say, oh, we randomize patients to receive the drug or the placebo, but they've got to be more specific. They've got to say, well, how did they do it? Because often investigators, they don't really know how to do randomization, but there are correct, approved and non-approved ways of doing it. It must be done in a proper way, because randomization is really the key to why randomized controlled trials are so effective. And then blindness of allocations means that the person doesn't know whether they're on drug A or drug B, and that should be imposed rigorously at the start of the randomized controlled trial, and ideally should be maintained throughout the study, especially if a subjective outcome is being measured, such as relief of pain or alleviation of depression. And all the patients enrolled into a trial should be properly accounted for at its conclusion. Finally, the trial must be reported adequately, and as a minimum, it should include a flow chart also called a trial profile. Sometimes there should be a flow chart which has various arrows coming out of it, depicting the progress of participants through the trial. And I finish here by saying the need to report randomized trials accurately was recognized in the mid-90s and has been reiterated many times since then.
And I think the paper that you refer to is Altman,
Yes.
and that is the first paper in the bundle, and it's at pages 1 to 2. Sorry, it's not. It's at pages 3 to 4.
Yes.
And I think it's entitled Better Reporting of Randomized Control Trials, the Consort Statement. But what does one attach to the consort statement?
The consort statement was a statement put out by clinicians and epidemiologists and statisticians in round about this time, and it was published in various journals, including British Medical Journal, The Lancet, JAMA. Wasn't published at that time in the New England Journal because they were resisting evidence-based, but eventually they came around. And Douglas Altman, who's a statistician who used to write beautiful little articles in a British Medical Journal of half a page on medical statistics every few issues, and he was a great proponent of evidence-based medicine. One of the founders of the Cochrane collaboration. I don't know him personally, but I went to some of his workshops. So what he's saying is that not only must the trials, the randomized controlled trials, this is what we want. We want RCTs because they're the best form of evidence. But not only must they be designed correctly, they must also be reported fully and accurately. That's essentially what he's saying there. And really,
I think if one is interested, one really, I don't need you to read through it, but
yeah.
one finds that in the first
Yes.
paragraph and the beginning of the second paragraph in his paper.
Yeah. Could I just read out one sentence?
Yes, please.
So, the key sentence, this is his starting point, and it's indisputable. This is 1996, and it's even more indisputable now than it was then. Only randomized trials allow valid inferences of cause and effect. Only randomized trials have the potential directly to affect patient care. So only from randomized trials can we have valid inferences of cause and effect.
So that's the second sentence in the first paragraph of that
Yeah.
of that paper.
Of course, but he goes on to say they still could be biased and there could
Yes.
be.
Right. Can we then move on to section 1.4, pooling scientific evidence? There's again a reference to Altman there, but could you read through what you say there, please?
So section 1.4, pooling scientific evidence. So pooling means merging scientific evidence, and really means merging numbers to get a slightly better number. So in recent years, systematic reviews have sought to pool evidence from RCTs. This is done through meta-analysis, which is a statistical method for that quantitatively summarizes the systematic review findings. Unpublished trials should ideally be identified and included in the meta-analysis to avoid publication bias. Publication bias means the non-inclusion of negative trials that are less likely to be published. So when you do a systematic review, you not only try and find all the papers that have been in print, but also the ones that would never saw the light of day because the journals rejected them or the authors got discouraged because they weren't showing what they expected. And that's all of that is relevant evidence if it's a randomized controlled trial. Meta-analysis results in a pooled estimate of effectiveness, which is more precise than the effect estimates from the individual randomized controlled trials. And this is because the pooled estimate is based on a larger number of participants and so is less liable to random error. And then it says some systematic reviews also look at non-randomized control evidence, and this might include qualitative research, animal studies, and modeling. But the core of a systematic review will be randomized controlled trials, and the review should systematically identify and evaluate, that is through an explicit and pre-specified and well-validated methodology, all appropriately designed studies that address the clinical question being considered. And where appropriate, the results of the included studies should be combined. And to be fully valid, a systematic review must satisfy a minimum of 3 criteria. It must try and identify all relevant studies, the published ones and the unpublished ones, and it must assess the quality of the studies, because some randomized controlled trials will be better than others. And it must try to combine the study results through meta-analysis, as long as it is reasonable to do so.
Right. Against that background, you go on to the Cochrane reviews.
Yes.
Can we just start a little with about the Cochrane reviews? I think we'll need to pause, because there are various matters that I need to look at in some detail with you in relation to Cochrane reviews. But perhaps you can just read on at page 6 of your report, please.
So a Cochrane review is a systematic review that uses methodology that has been tested and refined over a period of 3 decades by the Cochrane collaboration. And these reviews are prepared and maintained usually on a pro bono basis. Pro bono meaning that the reviewers are just volunteers, that they're not paid, by members of the collaboration working in small teams. In 1993, there were 100 members, active members of the Cochrane collaboration, but by early 2016, this number had grown to over 30,000 reviewers in more than 100 countries.
Pausing there, am I right in thinking you are a Cochrane reviewer?
Yes, I am. Yes, I've written 5 or 6 Cochrane reviews. Yes, yeah. I'm a reviewer in various fields.
Yes.
Not infectious disease, but also airways and the gut field. So I've been involved in different branches of the organisation. Yes.
I pick you up right by you saying that you've been a reviewer in relation to airwaves.
Yes, I wrote a Cochrane review that was to do with some exploring the same idea we had earlier about Helminth's treatment for allergic rhinitis.
Yes.
Actually, that was done under the auspices of Airways. We prepared another review that was looking at Helminth's treatment for asthma.
Mm-hmm. Right. If you just carry on, Doctor.
Yes. So historically, the focus has been on quantitative data, with study results combined using a software program called RevMan. And since 2003, the quality of included studies, included randomized controlled trials, has been assessed through the Cochrane risk of bias tool, and this automatically grades each included study into a high risk of bias, low risk of bias, or unclear risk of bias category. And that then allows the reviewers to do a reliable appraisal of the overall robustness or otherwise of the accumulated evidence. So if their accumulated summary evidence is based on not very reliable randomized controlled trials, they will place less confidence in that particular outcome. Whereas if it's based on very low bias studies, they will put they have more confidence in the outcome. And then an important feature of Cochrane reviews is that they're published electronically in the Cochrane library, and so clinicians, policymakers, and researchers can access them. And in most countries, including Britain, they can be downloaded free of charge, and that's because the cost of the Cochrane the Cochrane collaboration's overheads are met in part by the Department of Health, I think, or Department of Education, but there's a lot of government funding to support Cochrane reviewing in this country and in most countries, not all countries, but most countries. And so for better accessibility, every Cochrane review since 2001 has included what they call a plain language summary. So it's like an executive summary, a simple 1 or 2 page
summary to which I automatically go.
Well,
when I'm trying to understand
sure,
it.
Of course, because that's actually trying to get away from the jargon that is inevitable in scientific work. And it's trying to say, well, what does this actually mean in practice to the ordinary consumer of health, which is clearly the end user of these medical interventions, and so they're always well worth reading. And in addition, I have the standard abstract, which is introduction, methods, results, and conclusions. And the collaboration has its own press office, which promotes new reviews. And then Cochrane reviewers they're expected to update the review when there's a substantive new body of evidence, which means for many reviews about every 3 to 5 years.
Yep.
And that means actually, my lord, that the reviews that we might be looking at later on, by the time this inquiry finishes, will probably have been updated. And but it's unlikely there'll be significant differences. I think because the time to do randomized control trials in the COVID arena was in 2021 and 2022, and when moving to a different phase. So there'll be some modifications to the opinions, but they won't. I wouldn't have thought they would be that significant.
And I think just to conclude, Doctor, you refer to 3 Cochrane reviews, the 2 Jefferson reviews that we've looked at briefly in 2011 and 2023, and Gania, which is 2022, which relates to vaccines.
Vaccines for COVID-19.
For COVID-19,
yes.
I'm sorry, yes.
Yep.
COVID-19.
Yes.
And we'll look at those, I suggest, after lunch.
Yes, by all means. Well, we're a little early, so I had indicated that we should try and come back, or would have indicated we should have come back at 1:45, but could we make it 20 to 2, since we've got 5 minutes at this end? So about 20 to 2, please. Thank you very much. Croft would help. Right. Get Casky wandering. Right. Actually, when you're ready, Dr. Croft?
Oh, almost ready.
Almost ready. Just tell me when you are. Tell me when you are. When you're ready, Mr. Gill.
Thank you, Lord. Dr. Croft, we finished before lunch by looking at Cochrane reviews, the 3 that you have produced for our consideration, the 2 by Jefferson and the Grania review. And I'd like to ask you a little bit about the approach that one takes to those reviews. And can we do this under reference to Appendix 4 to your report, which is at page 105 and 106?
Yes.
And I think here we get into what are for most of us probably the dreaded statistics and analysis of that nature.
Yes.
Can we just look at what you set out there? Because you look at, I think, 3 concepts: odds ratios, risk ratios, and confidence intervals. And to begin with, can you explain and read what is meant by odds and odds ratios?
Yes. So all of these terms are used regularly in statistical analysis, which is, as I was explaining, is the process by which you you analyze the numbers that have derived from your studies, and they're common terms used by all investigators everywhere. So first of all, what is meant by odds and odds ratio? Odds and odds ratio are effect measures which are commonly used in the statistical analysis of research. And for a particular group, the odds is defined as the number of patients or participants who achieve the stated end point divided by the number of patients who don't. And so there's an example here. The odds of acne resolution during treatment with an antibiotic in a group of 10 patients may be 6-4 with resolution of acne. So 6-4, so 6 with the resolution of acne divided by 4 without. So the odds are therefore 1.5.
Yes.
In the control group, the odds may be 3-7, which is 0.43. And the odds ratio is the ratio of the two odds. And those are the figures, if you're going to try and summarize statistics from different studies, you will use. And the odds ratio is just the ratio of the odds of the treatment group to the odds of the control group. So in this case, the odds ratio would be 3.5, so that's 1.5 divided by 0.43. It's actually 3.488, but 3.5 for practical purposes. So if you have a study where you end up with an odds ratio of 1, that means actually there's no effect. What's happened in the treatment group, the intervention group, is really the same as the comparator group. People who are gamblers understand these terms instinctively, I'm told. But most of us struggle, but
Yes,
there's a lot.
I'm glad you say that.
Yeah, yeah.
Yes.
Okay, so the relative risk is risk and relative risk and risk ratio. The
Yes.
risk ratio is equivalent to relative risk. It's approaching the same the same goal by slightly different means. They're also used by researchers. And risk is slightly different to odds. So it's the number of patients who achieve the stated endpoint divided by the total number of patients. And so in the first example, the risk, those who achieve the stated endpoint who got better with the antibiotic would be 6 out of 10, so the risk is 0.6, you could think of risk as, in a way, as sort of what is the likelihood of achieving it? What is the absolute likelihood? So the likelihood of achieving is 0.6, which is you've got a 60% likelihood that you will get better with the antibiotic. Whereas those in the control group, 3 out of 10 of them got better anyway, so their risk of getting better was 0.3 or 30%. So even if you don't take the antibiotic, there's a 30% chance your acne will get better anyway. And so therefore that gives you a risk ratio of 6 divided by, so that gives you a risk ratio of 6 divided by 3, which is 2. Relative risk of 2 or risk ratio of 2. So again, if you're using this approach to analyze your statistics, if you end up with a relative risk of 1, it means there's no difference between your two groups. And often at that point, people are so discouraged by the negative results of their trial that they just don't bother to get it published, which is a shame because it nevertheless contains important information about the merits or otherwise of that particular intervention.
Can we move on to confidence intervals, please?
Yes, so the confidence interval is the next logical step and the last step that we need to go into here, and that really means how much confidence can you put in your findings, and by convention, by statistical convention, I'll read. All studies with control group, such as randomized controlled trials, are based only on a sample of the population. They're not based on the whole population. So there's always going to be some uncertainty about how reliable the effect measure calculated will be, based on the fact that it's just a sample. And the real effect, the true effect measure, may be larger than the measure that you've estimated, or it may be smaller. So as well as measuring the odds ratio or the relative risk, nowadays investigators are expected to calculate the parameters within which the true effect measure must lie with a 95% degree of confidence. And these parameters are known as a 95% confidence interval. 95% CI. I noticed Pfizer call them a 95% credibility interval, which is fine, but it's a new term to me. So the true effect measure, it may be higher than that you've estimated, or it may be lower, but there's a 95% chance that the true measure will lie somewhere between the upper boundary and the lower boundary of the 95% confidence intervals.
I'll just stop you there.
Yep, sure.
Who came up with the 95% figure?
I don't know whether anybody particular came up with it, but there was a time when 99% confidence intervals were much spoken about, but 95% just seems to be a pragmatic measure that is useful in clinical terms. But you're quite right, Mr. Gell.
And
it's arbitrary. It's arbitrary, but it's universal.
It's universal,
Yes.
but arbitrary and
Correct.
accepted.
Oh, absolutely,
Yes.
absolutely. And every scientific paper will have a 95. Well, the good ones will have 95% confidence intervals attached to the data if they can be calculated. It's not always possible to calculate them, but nearly always it is.
Right. Please continue. Just the last paragraph.
Yes. So in general, the larger the study, the larger the randomized controlled trial, the greater the likelihood that your estimated effect measure will be close to the true measure, because you're doing multiple observations in a rigorous and scientific way. Whereas if you've only got a very small study, the effect measure you've calculated may actually be inaccurate because it's based on small numbers. And so for small studies, you have wide confidence intervals. And for larger studies, you have smaller confidence intervals. So you have more and more and more confidence in your in your finding, in your calculated finding, if either you've done a large randomized controlled trial or you've done a systematic review combining trials of a similar kind through meta-analysis. That gives you a more precise estimate with smaller confidence intervals. I'll just go through these again because it's quite complicated. But so let's say you're covered with acne, Mr. Gell. You went to the GP and the GP said, "I've got a really good antibiotic for you, Mr. Gell. Here it is. It's going to really make you better." You could say to him, "Right, what are the odds I will get better?" And the GP would say, they'd look at a trial on the screen. So right, the odds are 6 to 10 you'll get better. So you'd say, right, okay, well the odds, and so therefore the odd, so therefore your odds would be 1.5, And so you think, right, that's quite good. But you say, what would the odds of my getting better, even if I don't take the antibiotic? And the GP would have to admit that it was going to be about 0.45, because some people don't take the antibiotic and they get better anyway. So you'd ask about what you'd say. Well, what's the odds ratio, doctor? So the doctor would say, right, okay, it's 3.5. So you think that was pretty good, and so then you might say, well, what about the risk? What's the risk? What's the risk I would get better? So you'd get a funny look from the TV, but they say, right, okay, the risk. So what you mean is, what's the likelihood you're going to get better? The absolute likelihood. And they'd say the risk is 60%. So your likelihood you're going to get better is 60%. And you'd say, right, okay, what in the control group, what was the risk that they got better? And the GP would say, well, the risk was 30% of them got better anyway. So then you'd say, right, okay, so the relative risk is only 2. You know, so that's things aren't looking that good, but they're still in the same order of magnitude. So you could then say, well, right, okay, well, what's the confidence intervals? And at that point, the GP would think, who is this crazy lunatic who's asking this? But it's a reasonable question to ask, because the confidence you could have in those small numbers wouldn't be that great. So the GP would have to concede there wasn't much confidence. So therefore, they'd have backtracked from an original position, which was, here's a really good antibiotic, to saying, well, it probably, well, there's some evidence that'll help you, but I don't have much confidence in the results. So then that's why you really need large trials and systematic reviews. And that's what evidence-based medicine's about. And we probably ought to use them more in our encounters with clinicians than we do. But we rely on their judgment. We rely really on them having sifted the evidence for us and arrived at those kind of conclusions.
And perhaps rely on the fact that a patient may not have the level of
sure.
understanding to ask those questions.
Yes, indeed, yeah. And one could say, well, individual patient encounters aren't that important, but of course they are.
Yes.
But by the same token, population level decisions are very important, and they should really be based on this kind of very careful weighing up of the pros and the cons and the confidence we can have in the scientific evidence behind the apparent measures of effect.
Right, can we perhaps look at this in operation? As I say, we have 3 Cochrane reviews.
Yes.
And can we look at just an example from the third of the Cochrane reviews, at least chronologically, and that is the Jefferson 2023 review. It's paper 9 in the bundle. I wonder if we could look at an example that is summarized at page 659.
Yep.
It's in the second volume, if one is looking at the reference them in volumes.
Yes.
And this is, it's headed Analysis 6.2. And the title is Comparison 6, Randomized Trials, Gargling Compared to Control, Outcome to SARS-CoV-2.
Yes.
Now, first of all, we can see that there are 2 trials that are referred to there. One is Almanza-Reyes 2021.
Yes.
The other one is Gutierrez-Garcia 2022. And just so we understand what these are, we can find the Almanza trial at pages 539 to 540. Perhaps we just look at that so we know what the context is. Almanza-Reyes is at 2021 is at the bottom of page 539. And we see there the methods, randomized controlled trial, randomized using a computer-generated block scheme and stratified according to duty, position, work shifts, and the area department of the service. We have to read that in context of what's followed on.
Yes.
Although I think the follow-up duration is said to be 9 weeks. Is that right?
Yes.
And at the bottom, we have a note of participants. And it says workers, doctors, nurses, administrators in a hospital for the exclusive recruitment of patients diagnosed with COVID-19, General Tijuana Hospital. And moving over, I think we can see that the interventions are then described, including experimental group mouthwash and nose rinse, and then silver mouthwash, and details are then given of that. And then mouth spray, and then the control group instructed to do mouthwash and nose rinse with a conventional mouthwash in the way they normally did before the study. So essentially, perhaps you can probably describe it much better than I can. What is being compared there?
The what they call the experimental group are asked to use this silver nanoparticle solution, mixed beautiful, and to mix it up with 20 mils of water and to gargle it for 15 to 30 seconds 3 times a day. That's, if you like, the treatment that's being tested here. Or alternatively, they could wash the inner part of their nose with a cotton swab twice a day. So there are two. Basically, the idea seems to be to sterilize their nasal passages, and as we will learn later, the virus that causes COVID-19 is predominantly in the nasopharynx in the early stages. So it's kind of a reasonable thing to do. One would have thought. And the control. What do the control group? The control group just do the mouthwash or the nose rinse or both, using a conventional mouthwash the way they normally do it. So they could use Listerine or water or anything that they might normally use as a mouthwash.
And the other trial is the Gutierrez-Garcia trial, which I think we'll find at page 567.
Yes. Yep.
The top of 567.
Yes.
And it's a single blind analyst randomized controlled trial carried out in a single center in Mexico City during September to November 2020. Randomization was through tokens in opaque envelopes, but the trial was open to all except the data analysts. There were some imbalances in age groups, but post-randomization at baseline in age and comorbidities. You translate that for us, please.
Well, so single blind means that those who were analysing the data, the statisticians didn't know what particular arm of the trial the participants belonged to, but the participants weren't blinded themselves because, as might become apparent, it might have been difficult to try and conceal what arm of the trial they were in. But that shouldn't matter as long as the randomization has been done correctly. And that's what we come on to next, I believe.
Right. Right. I think probably that's sufficient just at looking at those. Can we go back, please, to page 659?
Yes. Yes. So
and just before we do, I think the reason that this has been selected is that it's a two-study or or group comparator, and frankly, it's relatively straightforward.
Yes,
at least
exactly. It shows striking results.
Yes. So perhaps you can just take us through what is shown on that page?
Yes, so this is one of the analyses that the reviewers of this systematic review undertook. And when you do a systematic review, you do sometimes several dozen or even 100 analyses. And you're encouraged to present the most compelling ones in a chart like this, which is called a forest plot. You don't want to have 100 forest plots. You just want the most important one. So they've chosen this one because they obviously found it was of interest. And what they're comparing is gargling compared to control, which in this case was gargling with ordinary water or ordinary solution.
Can I just pause you there? What was the, I'll put it this way, the end product or the aimed for end product in this? What were they trying to seek to do?
They were trying to seek if SARS, interesting. Again, the outcome is whether the people who were gargling were less likely to develop COVID-19, the people who were gargling with the approved solutions, than the control group.
Right.
So the outcome was COVID-19 assessed through different methods.
Yeah.
And some of the trials, the COVID-19 is assessed subjectively by whether people felt they had a new onset cough and loss of smell and taste. But in other trials, it was assessed through laboratory measures. We haven't looked exactly to see how, but I think for these two, it was assessed by laboratory measures. So it was assessed quite robustly, I believe.
Yes. And what was the outcome?
But, well, looking at the going back to the forest plot, which is on page 659. Yes. So both of these trials, randomized controlled trials, were carried out in Mexico, it seems, which is interesting, and the numbers are quite large, and the square boxes give an indication of the size, the numbers of participants. Yes. in the individual trials. The diamond at the bottom indicates the combined effect of the trials. So the first line, if I read across it, my lord. So Almanza Reyes, that was one in Tijuana City, which is Mexico, I believe. Right. So they were looking at what they wanted to find out was gargling with this silver nanoparticles solution likely to have fewer people getting COVID-19 as compared to those who were gargling in the ordinary kind of way. And they had two events with the mouth rinse. I hope you can see that, two events. Yes. There are 114 people in total. So 2 out of the 114 acquired COVID, who were gargling with the silver nanoparticles. Would you agree with that, Mr. Gale? Yes, okay.
I'm taking your word for it, Dr. Croft.
Right, well, what about the control group?
Yes, I can see what it says, yes.
Remarkably, the control group had 33 cases of COVID-19 and out of a total of 117. So the total number of participants was 231, and they've been randomized into the gargling group and the control group. And the gargling group had very few cases, just 2, compared to 33, much higher number of cases in the control group there. And so they did the calculations we were just describing now, and they come out with a risk ratio of 0.06. And that means there's I think this is right, you're 94%, in roughly 94% more likely to get COVID in the if you're not gargling with a special solution. Yes. Than if you are. Yeah. So then Gutierrez Garcia, who did something similar, but they used a different solution. They were using, they weren't using silver nanoparticles, they were using neutral electrolyzed water to prevent COVID. And what did the control people must have used something else. Okay, not clear what the control, but anyway, the control people weren't using neutral electrolyzed water. They were followed up for only 2 weeks. They had similar results. In fact, similar results. Slightly smaller numbers. So, sorry, I should have said, beg your pardon. With the first one, Almanza Reyes, the horizontal line there, my lord, represents the 95% confidence interval for their calculated risk ratio. So the calculated risk ratio was 0.06, but the 95% confidence that they had in that ratio indicated that the true effect may lie anywhere between 0.02 to 0.25. But the key thing is that the confidence interval doesn't cross the line of no effect. The line of no effect is that central vertical line, which is 1. Mm-hmm. If it crossed 1, then you'd have to say the results suggest there might be an effect from gargling, but it's not statistically significant. But in this case, it is statistically significant. And then so Gutierrez Garcia, they had the gargling group comprised 84 people, and these were healthcare workers, I believe. Yeah, they were frontline healthcare workers, so very highly exposed to COVID. And I understand this was carried out in the first half of 2020. So those who were gargling had only one event where the individual received 1 out of 84 acquired COVID, and those who weren't gargling or who weren't using the electrolyzed water, neutral electrolyzed water, had 10 events. So they had a 10 out of 79. So the risk ratio there was 0.09, so not quite as good as the other people. The silver seems to be better, and that's plausible because silver seems to have virucidal and antibacterial properties. Nurses use it for silver dressings for burns. They're expensive dressings, but where you don't want any bacteria or viruses, you might use dressings. So their risk ratio wasn't quite as compelling, but it's nevertheless, there it is. It's 0.09. So they can say the study authors could say that this shows statistically that gargling using this neutral electrolyzed water will protect you from COVID within 95% bounds of credibility or probability. And then the Jefferson, the review authors have summarized they have pooled these results, and that's shown by the diamond there, which really gives a more precise measure of effect because the confidence intervals have been narrowed. The two horizontal corners of the diamond indicate the extent of confidence, and so therefore there's even more confidence now in this pooled result than there was in the individual results. And here we are. The risk ratio is 0.07, so they can say there's a 93% chance you won't get COVID under these circumstances, and the true and it might be as much as 98% chance you won't get COVID, but it might be as little as 77% chance. But the best estimate of effect is that 0.07 risk ratio that's been calculated in that way.
Given that there were 2 trials that were in comparison,
yes,
and relatively small numbers
yes,
in the intervention group of 114 and 84, in the control group of 117 and 79.
yes.
What degree of confidence would you take from a result such as that, and a comparison such as that?
Yes. Well, I'd take a lot, and this there are some numbers underneath that, my
yes.
lord. Tau, chi-square, and those numbers are indicating that they're different mathematical measures to indicate whether or not the 2 trials being assessed are kind of similar in terms of what's going on, the statistics.
Yeah.
And those numbers actually show that, particularly the I-squared is a measure of variability between the trials. And when there's an I-squared of 0, it means that the trials are very comparable, and you'd expect that you combine them without having to make qualifications. So it's entirely appropriate to combine those 2 trials. And if reading about the background of the trials, one could see why they turned out to be so comparable, because they're similar population and similar kind of intervention. So you wouldn't want to make any qualifications based on the fact that the results were a bit different. They were the same, and with very compelling results, you will get strong effect measures even with small numbers. You could get strong results even with small numbers, and I might mention the first first trial ever done was the James Lind trial, which had only 12 participants in, but proved pretty persuasively that the cause of scurvy was oranges. Sorry, the cure for scurvy was oranges and lemons. That was done in 1747. So that changed the whole understanding of scurvy, and became a model for future trials. That was more by good luck than by design, but it goes to show how you can even have just a handful of people in your trial, and provided you're on the right lines in investigating what is genuine, you could get reliable results just from tiny, really rather small numbers.
So is identifying comparators,
Yes.
is that an art or is it a science?
Perhaps a bit of both, but the key thing is that you should, at the outset of doing a systematic review, you identify what trials you're going to include and what nature of trials you're going to include and combine, and what ones you're not going to combine. So if you were going to do a trial, going back to the acne example, you wouldn't combine in this way a trial of acne treatments where some of the trials were using oral antibiotics and some were using topically applied antibiotic cream, because they're just too different. But you could well do a randomized controlled trial looking at different antibiotics just to answer the question, does antibiotic treatment cure acne?
Right. Could we look at another example of these measures in operation?
Yeah.
This time, can we look in the Grania report, and it's number 7, and at page 101 to 102, please.
Yes.
Now, sorry. Right, now, this is of course in relation to vaccines. And I think looking at 101, we have figure 13 and analysis 2.1.4. Non-replicating viral vector vaccine outcome,
Yes.
all-cause morbidity. And then there's a reference to Kulkarni 2021, and also to Voicey also 2021, and data pooled from 4 trials. So first of all, can we have a little bit of understanding of the terminology?
Yes.
Non-replicating viral vector vaccine, what's that?
Right. Well, we haven't really gone into the detail
We
of
haven't.
what the different sorts of vaccines are available, but essentially one category of vaccine against COVID-19 has been to use a virus that will enter a non-pathogenic virus, so a virus that's harmless to humans, that will enter the body and go into cells, but while going into cells will carry genetic instruction, but won't replicate, won't cause disease. It'll just carry the genetic instruction. And various of these non-pathogenic, non-replicating viruses have been used. The word vector means carrier, so they just use the carrier. Right. So possibly they're actually comparing slightly different trials, but nevertheless they're the same sort of trial because they're all using the same methodology.
Mm-hmm. And I think it's important to note, because we are taking this as an example at this stage,
Yes.
that the outcome that is looked at
Yes.
is all-cause mortality. So
Yes.
there isn't a suggestion of mortality being caused by the vaccine.
No.
It is a fact
Yes.
of mortality
Precisely.
post-vaccination.
That's right. Any mortality occurring during vaccination is what they're looking at, and
Yeah.
mortality is not a subjective event. It's a terminal event. You don't dispute it. So it's quite a good outcome to look at.
Now, can you just, again, as you did with the the gargling exercise. Can you just take us through what is shown in figure 13?
Okay. I'll have to put my glasses on for that. Perhaps I've got some reading glasses here, fortunately. You might have to lend, my lord, your magnifying glass.
Ah, I see.
Sorry.
It's all right.
And it's disappointing that the writing is very small, and I would hope that could be corrected in the future. Oh no, I'm all right. You might need them. So yeah. So what's happening here is they found 5. 1, 2, 3, 4, 5. They found 5 randomized controlled trials that are all done in 2021 that are looking at this important outcome. So that these vaccines of various kinds, where the way the vaccine works, or is assumed to work, is because the vaccine, it's based on a virus, a harmless virus that's carrying a genetic code. We could talk about that later on, into the cells of the recipient. And the whole purpose of the vaccination was, well, part of the purpose potentially was to prevent serious COVID-19, especially serious COVID-19 and death. So they're looking at death. So let's take the first line. Asano 2021. So have you got that, my lord? Mm-hmm. So they followed up the participants for 1.9 months. They gave them the vaccine. They followed them up for 1.9 months to see, and they were looking at other parameters as well, but they were recording how many died in that period of time. And that's the name of the vaccine, Chadox-1. It's the AstraZeneca vaccine, basically. And the group, Intervention 1, are the participants who received the vaccine. And Intervention 2 received placebo. Placebo means probably an injection of normal saline, so there was no active constituent. I suspect that was a single blind study. I'm not sure, but we could look up the details if we're particularly interested. So what happened? So how many deaths were there in the vaccination arm? And there were 0 out of 192. Yeah. How many deaths were? Is that right? Yeah. How many deaths were there in a placebo arm? Again, there was 0 out of 64. It's interesting, the two arms are different in numbers, and probably that's because the vaccination arm there were probably 3 arms, in fact, one with high-dose vaccine, one with low-dose vaccine, and then a third arm which was placebo. So it's a 3-armed trial, which is good. Just looking across to the extreme right-hand column, you can see that there was, according to the Cochrane Review authors, a well-designed trial with it was all green for the risk of bias. So there are various domains for bias, but they gave it a 5-star rating in terms of the study design. Yes. So the next one down is Fauci, 2021. This was a big study, and you can just, if we go straight to the numbers, again, they had 21,587 people who were given the vaccine, probably a high dose and then a low dose group, and 10,792 who just received placebo. They had no vaccine. Period of follow-up was 2 months. And so, just because there are so many people, you would expect some mortality in any event. But you might have expected there'd be less mortality at this time of high COVID from the vaccine group. So let's see if that was the case. And the vaccine group that was twice the size of the control group had 7 deaths, and the control group who just received saline had 7 deaths. Would you agree with that, my lord? Mm-hmm. And so therefore they've calculated an effect measure, which is that little tiny square. The square's tiny because it's just tiny transcription. But there's a very wide confidence interval there, because the numbers we're interested in, which is the deaths, are quite small. So those sort of numbers could have arisen by chance, is what we're saying here. And so because the upper end of the confidence intervals goes over the vertical line of no effect, the authors of that trial, if we actually looked at the trial, would have to say that it suggested there were fewer deaths, but we couldn't say that with statistical certainty. Statistically, it was not significant. But anyway, as we come to add more and more evidence, we might reach better significance. So the next study is Kulkarni. Is that right? Kulkarni 2021. They studied their participants for 6 months, which is good. I mean, really, you should study vaccine participants for a year or two, but you've got to put out interim results. They had 900 and 300. So 900 in the vaccine arm. Again, that suggests that there were two groups, a high-dose vaccine and a low or medium-dose vaccine group. And then there were 300 in the placebo arm. They had no deaths. Not quite clear why that was. Then Mardi, next one down, we've got 2 more to go. Mardi in 2021, they followed up their trial participants for 2 months. Again, so Kulkarni were using a different vector, a different vaccine. I don't know what that is. But there we are. That could be why they had no deaths. So Mardi had very small numbers, tiny numbers, only 52. They had 2 arms, only 52, and there were no deaths in the vaccine arm. 1 death in the placebo arm. So you could see the result, the little black dot, is on the side which says vaccine better, but the confidence intervals are so huge they're off the scale, because we're only talking about one finding there. But nevertheless, that contributes to the overall finding, which we're coming onto very soon. I think we're now on Voisey. Voisey, same sort of vaccine, followed 4.1 month follow-up, and Chadox. They used, so they had 2 type of control measures. One was men ACY, that's a vaccine against meningitis. So they used a dummy vaccine in effect as a comparator, which isn't ideal really. You should use placebo in vaccine trials. You should really use saline. But anyway, they had those 2 different sorts of controls. They had 12,282 participants who received the vaccine, the COVID-19 vaccine, and 11,962 who received the dummy vaccines or the placebo. And there are 2 deaths with COVID out of the COVID vaccinated ones, and 4 out of the COVID out of the control group. So again, their results do favour, do err on the side, or they land on the side of vaccine. Probably, well, you'd have thought it'd be better, but again, because the confidence intervals are so wide, they're very wide because of very tiny numbers. You couldn't say categorically that this was a statistically significant result. So here we are. So now we come to the if you like, the crunch, which is, what does that mean when you add all those figures together? And that's in the top blue diamond, the elongated blue diamond. And again, even though it's added the results from 3 trials, because 2 trials didn't contribute any of the data, the confidence interval still crosses the line of no effect. So even combining those data, you cannot say, which we'd like to say, you cannot say that using this vaccine prevents deaths. You couldn't say it. Now, it may be that no doubt there'll be other trials in progress that will add to the data in due course. And then as add to the data, the pooled estimate effect will get narrower as more data go into the analysis. It'll get narrower, and the confidence interval will get smaller. And then, as long as it's not touching the line of no effect, then you can impute a degree of confidence to that estimate of effect.
And again, from your perspective, what do you take from that?
Well, I read the data as it's presented, and I would immediately go back to the plain language summary, which we can all understand. And if I do that, I think from memory, the plain language summary just says the vaccines, we cannot with confidence say the vaccines prevent death, so let's do that.
Well, I think probably before we do that, actually, Dr. Croft, we'll come to that. And if anybody wants to read it, the plain language summary is at page 55.
Oh, right. Yeah.
But we'll come to that when we look at your section
Yes.
on vaccines.
Thank
I'm just using this
Yes.
at this stage as
Yes.
an example.
Yes. It's interesting. Yes, it's interesting. Even though the thousands of participants here, comparing to the gargling trials, where there weren't that many participants, but there was a very confident finding there. This really just indicates a very high level of uncertainty for this particular outcome.
Yes. And I think just for reference, anyone who's interested in it, there is a further analysis on the following page at 102, which is figure 14, analysis 2.1.5. Again, same non-replicating viral vector vaccine. The outcome that is looked at here is serious adverse events, SAEs. So one is not looking there at all-cause mortality.
No.
One is looking at serious adverse events. We will look at this again in the context of your passage in section 4 of your report on vaccines, but it is just to give the reference to that at this stage. Right. Dr. Croft, I think I can now, having done that exercise with you, move back to your report. And can we go to part 3? I'm sorry, part 2 of your report, beginning at page 8.
Yes.
Now, before we do this, because you're setting out here, and this is the longest passage within your report. It goes from page 8 to page 50 something. I can't remember the number, but it's the longest passage in your report. A lot of it is, this is not a criticism anyway, a lot of it is, in certain respects, a series of dates, and it is a narrative of what you see as significant events. But before we do that, could we just look at a little bit of background? And in particular, could we look at Appendix 4?
Yeah.
I'm sorry, I've got the wrong number. It's Appendix 7.
Yes.
It's at page 111 of your report. And I'll be asking you to look also at Appendix 8 and Appendix 9. And in these appendices, you give some background to previous pandemics and epidemics.
Yes.
And the first that you refer to is the immediate First World War influenza pandemic. I think is also known as Spanish flu. I think, as we can see, perhaps it was rather something of a misnomer for it. But perhaps you would just read through there and read through your comment on that.
Shall I read the part in italics as well?
Everything, if
Yes,
you would, please. Yes.
So, Appendix 7, the 1918 to 1919 influenza pandemic. The 1919 to 19 influenza pandemic, known also as the Spanish flu, has been described as amongst the most deadly events in recent human history. The pandemic killed between 50 to 100 million people, and in countries such as the UK and USA, and for reasons that haven't ever been adequately explained, there was a high case fatality rate at all ages, including amongst 20 to 40-year-old individuals. That's an age group who don't normally at low risk for severe influenza. However, in some countries, for example, Spain itself, the influenza took the form of normal seasonal flu with average or close to average mortality. So here I give my comment. I try not to interpose my comment in the main body of the report, but my report would be sort of bland and meaning and not have much meaning unless there was some comment at some point. So
No, I appreciate that.
Given my take on this, I made it clear this is my comment. So I've proposed here, the unusually high mortality in young adults with Spanish flu that occurred in some countries, such as UK and USA, is now thought to have been in large part because of harmful treatment protocols used in those countries, like UK and USA. In the early weeks of In the early weeks of the COVID-19 pandemic, the case fatality rate was also reported to be very high as 15%, and this caused widespread alarm. And this high reported rate may likewise have been due, at least in part, to harmful treatment protocols. And I give an example of some that might have been harmful instead of beneficial. For example, over-enthusiastic use of intravenous fluids, nursing patients in the supine, meaning on their backs rather than on their stomachs, and the sort of treatments that are no longer routinely used for COVID management. That's just a suggestion. And I put here the crude case fatality rate for COVID-19, averaged across all age groups, is now considered to be around 0.5 to 1%. I get that from, that's in the earlier section of my report. And in Scotland, I put it was only 0.29%. That was my own calculation. And the overwhelming majority of COVID-19 deaths occur in those who are very old, and that's overwhelmingly the highest risk factor. Those who are over 80 are the ones who are most likely to die, to get severe COVID and to die. Also the very sick, but that's less of a risk factor, having the pre-existing medical conditions. In 2020 and 2021, some commentators drew parallels between COVID-19 and the high mortality rates in young people that were reported in some countries during the Spanish flu epidemic of 1918 to 1919. Arguably, the drawing of these historical parallels was misleading and added to the atmosphere of panic that prevailed in 2020 and 21, and hence made easy the introduction in some countries of repressive and authoritarian response measures against COVID-19 that were often harmful at a societal level, but that were declared as necessary to contain SARS-CoV-2. And so I've appended within that opinion, or comment, I've got a scientific reference which talks about Spanish flu, and essentially what was happening there in the UK and USA was there were massive stocks of penicillin around, because First World War had just finished. Penicillin that was made had been made by Bayer, a German company, had gone off patent, so it was really, really cheap. And so doctors in large cities used this new wonder drug on patients, and were using it at such high doses that they were often damaging them and actually caused their death. And that wasn't understood properly at the time, but it was intuitively recognized as the pandemic progressed, and in later flu epidemics, aspirin doses were much lower. It's hard to prove, but it seems to be the case. That also would explain why in Spain, which Spain hadn't been in the war and so it didn't have massive stocks of aspirin, it was like ordinary seasonal influenza, a bit worse, but it wasn't killing young people in their tens of thousands.
I think you said earlier that massive stocks of penicillin. You're actually meaning.
I'm so sorry. I mean aspirin.
Aspirin,
yes. I mean
yes.
aspirin. Yeah, I do beg. Yeah. And so in the United States, they had this very frightening phenomenon of military barracks. They had very large military barracks of 10,000 troops or so, and there might have been sort of hundreds of deaths per day that were going on because the doctors were pumping the young soldiers with penicillin. Something aspirin. I'm probably confused. My own grandfather died in the Spanish flu. He was in the Merchant Navy, and he died in 1918, and he was in Portsmouth. And I suspect he probably got the full whack of aspirin and possibly killed him. It's a reasonable interpretation of the Spanish flu. Not to say it was probably a virulent form of influenza, but that particular influenza epidemic, and no other, especially affected healthy young people, and no one really knows why. And only in some countries, if it was really due to the very pathogenic nature of the pathogen, it would have been across the board, but it wasn't.
I think the
falls into category of informed conjecture by you.
Well, it's not by me. It's by other people. Yes,
other people,
it
yes,
is.
I
It
think,
is. Yes,
yes.
it is conformed. It's based on a reasonable scientific model. Yes,
Yeah.
I think the paper you refer to is the paper by Dr. Karen Sarko.
Yes.
And for those who want to look at it, it's document 18. The synopsis is at page 931. I don't think it's necessary to, unless there's anything there you want to particularly take from it.
I was simply going to say this isn't central to COVID-19, but it's an important pandemic that was the worst pandemic ever that has occurred, and there may be lessons we can draw from that.
Yes.
And I think that's one that numbers might be overstated for various reasons that are not actually truly related to the pathogen. They're just truly related to the way people responded to the pathogen with the best of intentions, but potentially making, in the first stages, patient worse rather than better.
No. And I think you make the point in your comments section at page 111
Yes.
that arguably the drawing of these historic parallels was misleading when one is looking at it in the context of COVID-19.
I think I'm right in saying many commentators were saying, "Oh, we're facing the worst pandemic since the Spanish flu of 1918-1919." But that was always misleading, because 1918-1919, there were a lot of young people who were affected, and this is very unusual with flu. But there's a potential explanation for that. Starko says that the case fatality rate in young people was as high as 3%. So it's a tremendously high rate of death, and so there's another explanation which could explain why that was.
Yes.
Whereas in COVID, it was never the case. It was never the case that young people were ever going to be a very high risk, because it was known from the very outset. It was the very old, and that could be inferred also from the fact that the previous coronavirus epidemic, with a very similar virus, SARS, which we might talk on shortly, it was known from that although it had a high mortality rate, it was in the very old. Yeah. So all I'm saying is that, of course, one can look back in history and cite examples of very serious public health events, but the particular imputation that was being, in many cases, given that we were facing widespread deaths of young people in the tens of thousands was not, in my view, appropriate on the occasions when it was used. I don't know if scientists were using it. I would hope not, but certainly media commentators were using it, and that obviously frightened people, because many people still have a folk memory of the 1919 Spanish flu.
And I think it's right to say, Doctor, that for those who suffered losses of family members and loved ones who were in the young group, that's probably of little comfort to them.
I agree. Yes, certainly. Yeah. Indeed, I would certainly accept that. Yeah.
Yes. Could we go on to Appendix 8, please? At page 112.
Yes.
And this is your reference to the 2009-2010 swine flu pandemic. And again, this is a more modern history, and probably something that we all remember to a certain extent. The H1N1 is sort of letters and numbers embossed in our memory.
Yes.
But perhaps you could just read out the block section at the top and then your comment on it.
Yes, so the block section I've taken from a standard textbook of microbiology, the Oxford Handbook of Infectious Diseases and Microbiology, and summarizes the swine flu pandemic in a few sentences. The H1N1 swine flu pandemic of 2009 to 2010 spread rapidly throughout the world. Rates of infection were highest in those less than 25 years old, and unlike seasonal flu, low in those over 65. And the explanation for that might have been that the over 65s already had some pre-existing immunity to that particular virus because they'd encountered it in the 50s, 1950s, whereas the young people didn't. So the young people were getting affected, but they weren't dying particularly on the whole. Secondary attack rates were probably similar to those of seasonal flu, but rates of hospitalization and mortality were higher, especially amongst the pregnant and immunosuppressed. Interestingly, they weren't higher amongst the very old, probably for the reason we've just suggested, that the very old had probably encountered something like this virus in their youth. But it was the pregnant and immunosuppressed who were hospitalized and who were likely to die. So unlike the seasonal influenza virus H1N1 circulating at the time, this is important, less than 99% of the pandemic swine flu strains were susceptible to Tamiflu, which is the drug that the government bought in very large quantities. It's called oseltamivir. Its trade name is Tamiflu. So the government, in response to this pandemic, the World Health Organization declared it a pandemic. They bought in very large stocks of an antiviral drug on the assumption that it would reduce symptoms and reduce pressures on healthcare. But basically, the strain was resistant to it. It really had no effect, or very little effect. And then by the following season, this new pandemic strain of the virus had become just the standard circulating influenza strain. It merged into the background strain of influenza viruses that cause pandemic, seasonal flu, and it's now a seasonal. It's considered a seasonal virus. So it was alarming. It was rather alarming when it first appeared. Some people died. Some people got ill. Not that many. But that particular pandemic fizzled out. It started in about. It was declared in the sort of middle of the year, 2009. It built up a head of steam during the autumn, and at Christmas time it just fizzled out completely. I remember being working in the Surgeon General's department then. We were having to implement the policies of getting vaccines out to outlying military stations, and we came back from Christmas in January, and no one was talking about it anymore. It was all a bit embarrassing. It was no longer regarded as being a serious threat at all. There was then an official inquiry, the Deirdre Hine report, which came out very quickly. She reported in July 2010, and it's a very, very good report actually, which I read just recently, and she made some very perceptive observations. So here's my comment. Again, this is just my personal view, which I accept as my personal view, and I've qualified at the beginning of the report that my personal view is not necessarily or not to be taken as in any way indicative of the inquiry's view, but I've said here, the above short summary of the 2009 to 2010 swine flu pandemic, taken from a standard textbook, the response to the pandemic by the UK government at the time, which was the Labour government of Gordon Brown, was unduly influenced by worst-case modelling, and that was something Deirdre Hine mentions in her executive summary. She said, people keep using this term, this is a reasonable worst-case scenario. It's a reasonable worst-case scenario that millions of people are going to die in this country. She said that, a worst-case scenario cannot be reasonable, is I think what she's saying, and I think lawyers would understand that. So it was influenced by worst-case modelling and by alarmist predictions in the media that originated from WHO officials and UK academics who had undeclared conflicts of interest. And that's now well established. There was a remarkable paper by Kate Mandeville and some colleagues at the London School of Hygiene who looked at what scientists were telling the media, what stories they're feeding to the media. It's one of my attached papers.
Just to give
yes.
the reference to that is at pages, booked out, 808 to, it's a short paper.
Didn't come out till 2014, so 4 years after it was all over.
2814.
Yeah, yes, thank you. 4 years after it was all over, these investigators, this is what they said. They said, well, essentially they said, There's evidence of conflict of interest amongst academics providing media commentary during the early swine flu pandemic. And this led to heightened risk assessments. I'm reading from the abstract of that paper, conclusions. Heightened risk assessments combined with advocacy for pharmaceutical products to counter this risk may lead to increased public anxiety and demand. And then they finish with the line, academics should declare and journalists should report relevant conflicts of interest for media interviews.
Right, I think just again for the note, you're reading there at
I'm reading at
page 808,
808.
in the abstract and
Yes.
the conclusion section.
Correct, yes. Yes.
Okay. Right. We go back to your comment.
Yes, I put here, in fact, the swine flu pandemic quickly reached a state of natural equilibrium by early 2010. In fact, it was already declining by November of 2009. It was already reached its peak and was waning. But anyway, by early 2010, it was all over. Here we are. Important additional mistakes made in 2009 to 2010 by the UK government. It's great to be wise with hindsight, but here are the additional mistakes. Included, 1, the stockpiling at great expense to the UK taxpayer of ineffective antiviral drugs, notably oseltamivir or Tamiflu. And here I cite the editor of the British Medical Journal, Fiona Godley, who said exactly that in 2010. She said, we've spent billions on completely ineffective antiviral drugs. Other countries were not panicked into this position, but Britain was, France was, Poland wasn't, and she said this is not acceptable. And then I put 2, here's an additional mistake, emergency use authorization given to inadequately tested vaccines, notably the GlaxoSmithKline vaccine Pandemrix, which in a significant but undisclosed number of children caused narcolepsy, a devastating and lifelong neurological disease. So there wasn't any vaccine around to counter this new strain of influenza, which was serious in pregnant women and those who are immunosuppressed. So the process of authorization for vaccine use was speeded up, and some vaccines were repurposed from seasonal flu to be used against this new variant of flu. One of these was Pandemrix, and it had very terrible side effect in a small number of children, but it was nevertheless a significant number, some hundreds of children who had developed this very severe neurological disease as a result of this vaccine. Obviously, it was contested. The manufacturers contested. They said association doesn't mean proof, but it is now in the textbooks that particular vaccine was a very unfortunate cause of this incurable condition. And the following year, or maybe the year after, it was withdrawn. It was being slowly developed for use in seasonal influenza, but the manufacturer, GlaxoSmithKline, withdrew it. Unfortunately, the government had committed to buying large quantities of this vaccine, along with another vaccine, which actually seems to have been quite effective, but didn't cause neurological problems. But GlaxoSmithKline they wouldn't allow a break clause. This is one of the criticisms Deirdre Hine makes in their report. So in other words, they wouldn't say, all right, we'll take the vaccine back. Now you don't want it. They said, no, you've got to pay for it. So that was a lesson that was identified then.
Just to give the reference
Yes.
to the Godley piece, that is document number 6 in the bundle, and it's at pages 48 to 49 of the bundle. And I think, as you said, Fiona Godley was the then editor-in-chief of the BMJ, is that right?
She still is, yes.
And still is,
Yes.
yes. And this was, effectively, as I understand it, it's headed, this was an editorial article by her.
Yes. Yes. She's also very critical of secret emergency committees, and very, very hard-hitting editorial, and short, nice, well worth reading. She also talks about independent experts and how hard they are to find. It's quite interesting. Experts who are involved with industry could be consulted. She's really talking about government departments. You could consult experts on vaccines and pharmaceutical products like antivirals who are involved with industry, but she says they should be consulted but excluded from decision making. So there we are. And she said, as for the World Health Organization, its credibility has been badly damaged, and then she goes on to enlarge on that point.
Right. Thank you, Doctor.
Thank you.
We're going on to Appendix 9, which will maybe take a little while, perhaps more than 5 minutes, so perhaps an opportune moment to stop.
Yep. Just choose your moment, Mr. Gill.
I've chosen.
You've chosen. Okay. I thought you said in a few minutes. Very well, we'll take 15 minutes, which makes it broadly 3:10. Good.
Dr. Croft, can we go to Appendix 9, please? Pages 113 to 114 of your report, where you look at previous coronavirus epidemics. Now, I know you're going to be referring to SARS and MERS as we progress through section 2 of your report, but it's perhaps useful to take what we have here and perhaps you, again, if you do what we've done in the past with the other appendices, could you read through the block sections and then your comment?
Yes. This Appendix 9 is about previous coronavirus epidemics. Until about 2000, there were 4 known coronaviruses, just by way of background, but it wasn't thought that they were particularly dangerous. They just caused upper respiratory tract infections and colds. But then these 2 novel coronaviruses came along, which caused quite serious epidemics, particularly the first one, SARS, and the second one, MERS. And of course, as we know, COVID-19 is caused by yet another novel coronavirus. So first of all, severe acute respiratory syndrome, SARS coronavirus. These 2 sections, again from a standard textbook, 2017. So this was knowledge. This is accepted knowledge, and it was known at the time of the COVID-19 outbreak. So SARS, S-A-R-S, was recognized in China in November 2002 and had spread to affect 29 countries across the world by February 2003. I think there were 3 cases in the United Kingdom, no deaths. The epidemic died out by July 2003, and in total 8,096 cases were reported with a case fatality rate of 11%. 43% were in those over 60. I think that was skewed very much towards the over 70, over 80. There we are. Between July 2003 and May 2004, there were 4 small and rapidly contained outbreaks of SARS, and 3 of them were associated with laboratory releases, and the 4th was thought to be due to an animal source. The cause was a novel coronavirus. Animals are thought to be the main reservoir. Transmission is by droplets and contact with contaminated surfaces. Nosocomial transmission, nosocomial means hospital-associated, hospital-acquired transmission, was common in the early stages of the outbreak. The virus is present in stool and may cause diarrhea. And so 3 bullet points: clinical features, diagnosis and treatment. Clinical features: incubation 2 to 10 days. 3 to 7 day febrile prodrome, that means a pre-illness phase when you're not feeling quite right, but you're not entirely unwell, you just don't feel right. So there's this early period of feeling unwell, notable for the absence of upper respiratory symptoms, and then the respiratory phase typically starts abruptly with a dry cough, progressing to breathlessness and progressive pulmonary infiltrates on chest X-ray. Diagnosis: during the outbreak, reverse transcriptase polymerase chain reaction was performed, but sensitivity appeared to be limited. Sensitivity is more or less the ability of the test to pick up cases, and the testing was less than 70% positive on NPAs. I think that means nasopharyngeal aspirates in week 2 of the illness. No systematic study was performed to validate tests. Serological testing by ELISA, and that means testing for antibodies. That's what serology is. ELISA is enzyme-linked immunoassays. It's a technique for estimating antibody levels. At 3 weeks appeared to be most sensitive. This is important. I think treatment: no specific therapy. Care is supportive. Patient isolation and infection control precautions were key to the control of the outbreak, and this was facilitated by the long prodrome, so cases could be identified early and isolated before they became infectious. That's all very, very, very relevant, I think, my lord, because when SARS-CoV-2 came along, the virus was very similar to SARS virus. Quite a lot of work had been done on it. It was 79.5% similarity to previous virus, and very many of the features of SARS-CoV-2 had already been seen in SARS, which, as we've just read, died out. So Middle East respiratory syndrome, that was rather different, although still a coronavirus. It's a virus that's closely related to several bat coronaviruses, and they were identified. This was identified in 2012 from a man admitted to hospital in Saudi Arabia who had pneumonia and renal failure, and about the same time, an identical virus was identified in Qatar, and a patient with similar features who'd been to Saudi Arabia. Then there were cases all around the Middle East and 5 other countries from patients who'd returned from the Middle East. And UK, France, Italy and Tunisia reported limited human-to-human transmission to close contacts of the index cases. And this had a very high case fatality rate of 60%. I don't know why. I don't think anybody knows why that was, but luckily didn't spread. Clinical features: incubation period of around 5 days, but less than 10 days. Symptoms ranged from none, in brackets, positive reverse transcriptase polymerase chain reaction tests were found in several asymptomatic close contacts. So in other words, they had the infection, but they had no symptoms. Mild respiratory illness in some, and severe pneumonia requiring ventilation or extracorporeal membrane oxygenation at the most extreme end. And so here's other symptoms: pericarditis, that's inflammation of the pericardium of the heart; renal failure, DIC is disseminated intravascular coagulopathy, which is a clotting disorder, and diarrhea. Those with underlying medical problems seem at greater risk of severe disease. And then diagnosis: reverse transcriptase polymerase chain reaction testing. The lower respiratory tract specimens is the most sensitive. We all know PCR testing is probably best. Testing multiple specimens at different times at different sites increases the likelihood of detecting virus. Guidance should be sought from national public health authorities as to who to test based on contemporary epidemiology. Again, treatment is supportive and infection control paramount.
Before we go on to your comments section, Doctor,
Yes.
a couple of points.
Mm-hmm.
In relation to SARS, I think you say that animals are thought to be the main reservoir.
Yes.
Can you explain that, please?
That will be explained later on if we go to that particular point of my part 2. But
Right.
the coronavirus has 79.979. Sorry, the virus here was. I'm not quite sure what animals it was thought to have come from. I can't be certain, but could well have been bats as well. Please accept my apologies on that.
No.
Yeah.
We'll come back to that
Sure.
if needs be.
Yeah.
There are 2 references
Yes.
in both SARS and MERS
Yes.
to care is supportive.
Yes. Yes.
What is that meant to signify?
That is meant to signify is that during these emergencies, and the first one was an emergency especially in China, the second one was an emergency in the Middle East, there would have been attempts to use antiviral drugs and extreme, or should we say, what could be called aggressive medical interventions to save the patients who were getting unwell, but they weren't successful. So, essentially, the standard, the accepted wisdom as regards these 2 viruses, which are still around, but they're not causing problems, is if you get a patient with them, just nurse them with ordinary nursing care. Don't try anything fancy. It may make them worse. That's put into very simplistic terms, but that's what supportive care means. It means give them oral fluids, give them painkillers, simple painkillers, but don't sort of get out your antiviral drugs from the cupboard just because they're there and see if it's going to help them, because it probably may make them worse.
Is that viewed as being almost what one might term palliative care?
Yes. Although palliative care has connotations that the person is going to die.
Yes.
Supportive care has connotation the person is going to recover.
Yes.
They're more likely to recover, so therefore
Yes, I wanted to make that distinction.
Yes,
Yes.
indeed, yeah.
Yes. Right, if you go on to your comments section, Doctor, please.
Thank you, yes. Again, my lord, these are my interpretations, because the data is very, very, very bland. so I've put the above short summaries of SARS and MERS epidemics, and interestingly, WHO never designated them as pandemics, and that they could have been, but they weren't. They're taken from standard textbooks for medical students. This knowledge was available when COVID-19 started in March 2020, and like the swine flu pandemic of 2009 to 2010, the MERS pandemic of 2012 proved to be self-limiting, although there still are sporadic cases. So MERS seems to be over. It seems to be over as a kind of major public health threat, but SARS is somewhat different. The 2002-2003 SARS epidemic, first recognized in China, then spread to 28 other countries, so it was widespread. It was also self-limiting, since most of those countries didn't adopt emergency measures against SARS particularly, and yet the epidemic died out. I'm sorry, there's a typographical error. The epidemic died out by July 2003.
Yes.
Yeah. So whereas in all other countries, so we had SARS in this country, we didn't go into emergency state. There were prudent measures taken, but in China, by contrast, they went into full lockdown mode. This is when lockdown was invented, and I call them a series of repressive and authoritarian measures, including lockdowns, meaning closures of schools, workplaces, entertainment venues, and stay-at-home orders. And then social distancing was imposed in China, enforced spatial separation of at least 1 meter between those infected and those non-infected, and they had border closures and compulsory face mask wearing. They were all mandated by the Communist Party of China. So I've written, these extreme government-mandated measures were afterwards judged by the Chinese government, but without any scientific evidence, any rigorous scientific evidence to support this judgment, to have resulted in the containment of the SARS epidemic. And they used exactly the same package of measures when COVID-19 came along, because in their view, they'd worked. But in fact, they had the worst experience of SARS of any country. So a contrary view would be that their extreme package of measures made what should have an epidemic that should have reached natural equilibrium quickly. It actually prolonged it.
Would that be possibly through containment of individuals in close proximity to each other?
Yes, indeed. So if people were being contained in their flats during the winter in conditions where a virus that wasn't that transmissible would easily infect the other person in the same apartment, then that would provide a micro focus of infection that would perpetuate the infection. Whereas if they'd been allowed to go about their ordinary business, that may not have occurred to the same degree.
Yes.
So, and in respect to SARS, China was the worst affected country by a wide margin, and especially as I repeat, in the very old, the over 80s, that they were the group that were really very, very much at risk of death. Secondary attack rates of coronavirus within households are high, so the containment measures against SARS, I put in containment in inverted commas because this is one of Deirdre Hines' points, that you cannot contain these respiratory transmitted viruses. You can slow their spread, but the idea that you can contain them isn't possible with that sort of transmission.
You just remind us who Deirdre Hines is.
I beg your pardon, Ms. Kelly. Deirdre Hines was appointed to she was chair, like Lord Brailsford, of the official inquiry after the swine flu epidemic. And she wrote her inquiry report in July 2010. And she doesn't like the phrase reasonable worst case scenario. She has contradiction in terms and engenders unreasonable planning. And she doesn't like the phrase containment. She doesn't like the concept of containment, even though they were talking all the time then about containing swine flu. So the containment measures, the containment in inverted commas, measures against SARS that were adopted by the Communist Party of China may have made the SARS experience worse, not better, and for example by creating hundreds of new foci for the ready acquisition of SARS in people's homes. And notwithstanding these uncertainties, exactly the same package of 2002-2003 repressive and authoritative measures, but with additional new measure of population-wide electronic surveillance of citizens' movements was adopted by the Communist Party of China in 2019-2020 at the very start of the COVID-19 pandemic. They adopted the same measures in January 2020. In early 2020, with high COVID-19 case numbers occurring in most countries, including China itself, the Chinese model of coronavirus, in brackets, inverted commas, containment, was adopted by many other governments, including the UK and Scottish governments. In Scotland, 2 population-wide electronic surveillance schemes on the Chinese model were procured, and these were 1, Test and Protect, procured by the Scottish Government in May 2020, and 2, Protect Scotland, procured in September 2020. I don't know much about them, but I got that data from the timeline that's on the website.
Mm-hmm.
In England, the measure that was adopted there was procured in 2020 by the then Secretary of State for Health, Matt Hancock, called Track and Trace. And I do know that it was hugely expensive and it was not at all effective. So I end up by saying that there's no evidence of any effectiveness of these population-wide electronic surveillance schemes, as far as I know, in helping to spread SARS-CoV-2 infection.
Right, we'll come back to some of that
Yes.
as we progress on, particularly in section 3. But if we now go back to your statement, please, at section 2,
Yeah.
I think it's page 8. Yes, page 8, the COVID-19 pandemic. Now, again, Dr. Croft, if you would read through that, and I think, fortunately, I probably don't have to interrupt you very often on this, because I think it is largely factual.
Yes.
So if you would start reading at 2.1 and
Yes.
continue.
Thank you. So 2.1, what is COVID-19? COVID-19 is a syndrome, and that's a jargon term meaning a multi-system illness caused by a virus which we now know as SARS-CoV-2. And in the UK, it's a statutorily notifiable disease, meaning that if doctors diagnose or suspect it, they have to report it to the local authority. COVID-19 is a varying presentation ranging from asymptomatic or insignificant to respiratory distress and death. The disease is milder in children, with the greatest risk of severe illness and death in those aged 85 years and older. SARS-CoV-2 was responsible for a global pandemic in 2020 to 23. The pandemic's now been declared over. The pandemic has been associated with severe negative impact in most countries, with decreases in gross domestic product and an increase in inequalities among lower socioeconomic groups. Quite a strong statement. I've taken it from standard text, but everything here is from standard medical textbooks.
Yes.
So I consider it would be not contested, my lord. And then the last paragraph here, which is interesting. A subset of individuals. Oh, I beg your pardon. That's wrong. A subset of individuals with SARS-CoV-2 infection have progressed to a recurring pattern of physical and cognitive symptoms known as long COVID. The public health measures used to manage the pandemic have also led to social isolation with adverse mental health consequences.
Right. Having said I wasn't going to interrupt you, I'll now contradict myself and do so. Two things I'd like just to clarify.
Yes.
First sentence in 2.1, you refer to a multi-system illness.
Oh, yes.
Again, that may be probably self-evident, but
yes.
can you just explain what that is?
By multi-system is many body systems, so it's an illness that could affect the brain, the lungs, the heart, the kidneys, the liver, the lymph nodes. Just pretty much any system in the body could potentially be caused by SARS, although we have tended to regard it as a respiratory illness. There are people who are quite ill, but their lungs are fine, so there are many dimensions to this illness.
Right. And in the third paragraph on that page, You make reference to severe and negative impacts in most countries,
Yes.
decreases in GDP and an increase in inequalities among lower socio-economic groups. And then you also go on in the next paragraph to say the public health measures used to manage the pandemic have also led to social isolation with severe mental health consequences.
Yes.
Now, can I just understand, put yourself, Dr. Croft, in the situation of someone with your public health and epidemiological background
Yeah.
who is asked to advise either a public body such as a government or a public body such as an authority
Yes.
or a commercial organization or a local authority
Yes.
about restrictive measures that may be thought are being considered so as to combat COVID-19.
Yes.
Within your area of expertise, would you feel it appropriate for you to highlight what you might envisage to be the negative aspects of restrictions such as you've identified here?
I would expect to, I would look at economists to give detail on the economic damage that says that was caused, and mental health experts to talk about the adverse mental health consequences. What I'm really doing here is in a way providing what appears to be incontestable knowledge that such consequences did occur.
Well, we've got that, I suppose, with the benefit of hindsight.
We have, yes.
But
yes.
at the time
Yes.
of formulating restrictions,
Yeah.
would you issue, as it were, a warning in relation to these issues?
Yes, I have worked in policy making to an extent, and when I was doing it, we would normally make a recommendation, and there would be what we call an impact statement. There might be some other jargon, and the impact of this policy would be blah blah blah, and so therefore there would be a recognition that every policy decision would have some kind of knock-on effect that would often be undesirable. So in making any policy decisions which might or not be taken up, I would expect there to have been something like an impact statement that this will have the following potential consequences in these areas of society, because these were measures that were affecting the public at large. They weren't individual measures.
So again, from your perspective as
Yes.
a public health practitioner
Yes.
and consultant and specialist,
Yes.
if you were considering with policymakers
Yes.
matters such as isolation
Yes.
of elderly people in care homes,
Yes. Yeah.
would you, again,
Hmm.
as that policy was being considered, think it appropriate to issue some form of caution, if I can put it that way, about the potentially adverse consequences of that?
I would expect it to form part of the decision-making process.
Yes.
But whether or not the government went so far as to put out a health warning, so to speak, that incidentally we're now going to see many more cases of mental illness and social isolation would just depend on the context. And that would just really be a matter of how expedient it was thought to be. But it's similar to, again, going back to going to the general practitioner. The general practitioner would say, try these pills, and I have to tell you that there are some side effects associated with them. So it would, or they can necessarily assume that because there's a package insert telling you about the side effects, that would be part and parcel of the contract between yourself and the general practitioner. But all decisions that affect the public health have consequences beyond the immediate ones, and they need to be taken into account.
And within your discipline,
Yes.
of being a public health practitioner, would you feel both competent and confident in at least alerting a decision maker or
Yes.
potential decision maker to these potentially deleterious effects?
Yes, although it may not be the case that the exact detail of the deleterious effects might fall outside my immediate competence.
Yes.
So if they were economic or educational, for example, but I would have to at least alert the decision maker that there would be consequences of that
Yes.
nature. Sometimes it'd be self-evident, but they might need to be spelt out, that more factors need to be taken into account than just the medical benefit to be derived.
So, for example, do you find it in any way surprising that social isolation had adverse mental health consequences?
I think that would be a foreseeable and regrettable consequence of the social isolation, the mental health sequelae.
Yes.
Yeah. We are social animals, and we have to associate with other people, and when we can't, we suffer consequences.
Yes. Right. Could we go on to section 2.2 at page 9, please? And if you just read on.
Yes. So here we talk about viruses. What are viruses? Viruses are small, 20 to 150 nanometer protein packages. They are much smaller than other infectious agents. Viruses have a central nucleic acid core, which is genome, they call it the genome, surrounded by a protective coat called the capsid that is antigenically unique for a particular virus. The virus genome consists of either DNA, which is deoxyribonucleic acid, or RNA, which is ribonucleic acid, but not both, so it's one or the other.
Right. Can I just stop you there,
Yes.
Doctor? It might be helpful, although it's coming subsequently in your report, if you refer to the figure at
Oh yes.
page 14 under the heading 2.5,
Yes.
what characterizes SARS-CoV-2.
Yes.
And it's perhaps useful if
Oh, yes.
if you can describe what is a virus under reference to that figure.
Yes. Shall I explain some of those terms?
It would be helpful,
Yeah.
I think, yes.
Thanks. I'll come back to that as
Yeah.
and when. So, just there's a lot of jargon, but I think we need to understand it, because when we come to the papers,
Yes.
the investigators use these terms. So the genome means the entirety of the genetic construction of an organism. It's what it is that makes the organism what it is. We each have a genome. The capsid is a protective coat. So we go on to say the virus genome consists of DNA, that's explained there, RNA, ribonucleic acid, but not both. So DNA and RNA are nucleic acids.
Yes.
They're classed as nucleic acids, and nucleic acids consist of many nucleotides that are joined together, but bonded together. And a nucleotide is a sugar and a phosphate base. This is biochemistry, and then a sugar and phosphate element with a nitrogenous base attached to it. And then that nitrogenous base may be, in the case of DNA, it's guanine, adenine, cytosine, or thymine. And in the case of RNA, the nitrogenous base may be guanine, adenine, cytosine, or uracil. So they use 4 of those bases, and that gives it its particular characteristic. that the bases can change around, and that's part of the process of mutation that RNA and DNA can undergo. Yeah. So, don't think we can really refer. So, looking at the figure, so there's on page 14 of my report, there's the virus that causes COVID-19. It's called SARS-CoV-2, and the RNA is in the middle of the virus there, and that's the genetic constituent of the virus. The viral genome is that totality of viral RNA that's in the middle of the virus there. In humans, the genome is contained within the nucleus of the cell. Right. We're probably coming on to that later, but in viruses don't have a nucleus as such, so the RNA, the genome is sort of scattered around within the middle portion of the virus. Have we said it's? Oh yeah, and the next paragraph down. So you can see the envelope around the RNA virus. We're going to that comes in the next paragraph on page 2.2. The envelope. So some viruses, for example, coronaviruses, have an outer envelope which consists of lipids, fat, and protein. And this is important because envelope viruses can't survive as well in the environment, so they have to get quickly from one infected person to the next, and so they're spread by respiratory, sexual, bloodborne routes. Non-envelope viruses survive better in the environment, and they're predominantly transmitted by fecal-oral routes or respiratory routes. So coronaviruses then are enveloped, and they can't survive as well in the environment.
Yes.
That has implications for ventilation of rooms and being out of doors. The viruses just don't survive very long outdoors, and they survive for better periods indoors and in contained environments. Some viruses contain enzymes. We're back to section 2.2. So HIV, human immunodeficiency virus, contains an enzyme called reverse transcriptase. Then we talk about viruses being grouped into orders, families, subfamilies, and genera. A lot of shall we say, uncertainty about how to group viruses, and at the moment only about half of viruses have actually been properly classified, and the classification may change. Viruses have colonized most life forms, including bacteria, plants, insects, and animals, but viruses are not alive. They are metabolically inert, so they're metabolically not metabolizing, so they have to live intracellularly within the cells of their hosts, and they can't replicate independently. So the virus on the surface there can't produce more viruses. It has to get into a host, a living host, in order to replicate. So what they do is they subvert host cellular processes in order to synthesize their nucleic acids. So
right, I think you're going to have to explain that.
I'm so sorry, it's an exact quote from this Oxford. So what this means is that they get into the cell. The cells do know how to produce new cells. Viruses can't really do it. So they have to take over the cell's replicating functions in order to synthesize their nucleic acids, to create more RNA copies of themselves or DNA copies of themselves, and then they multiply within the cells, and then they burst out of the cells into the extracellular environment and penetrate new cells, and then the same process repeats itself. So there's a time element involved in viral infection. They can do this pretty quickly, but a virus won't infect you one day and won't infect you and then kill you an hour later, because it needs time to get into the cells, replicate, get into more cells, replicate, get into more cells.
Yeah.
But because they're in the cells, I'm sorry, extemporary, but because they're in the cells, you can't treat viruses with antibiotics in the way you can treat bacteria that are generally extracellular. You have to use, you could possibly use antiviral drugs that interfere with some of those replicating strategies, but generally viruses don't respond to antibiotics, and this has important treatment implications. So we're saying now that whereas bacteria may have several thousand genes, and a gene is the basic unit of heredity. A gene is defined as a small section of, well, in humans, a gene is a small section of DNA. We've said DNA is deoxyribonucleic acid, and a gene is a little section of DNA that codes for a particular protein. The proteins are the substances in our body that actually do things, rather than just being inert like fats and sugars. Proteins do things, and 20,000 proteins in our body. Many of them we don't really know what they do, but some of them have clearly defined functions like hemoglobin, which carries oxygen from the lungs to the tissues as a protein. So what a gene does, it'll instruct the body to produce a particular protein. So viruses have the ability to produce more than one protein from the same gene by means of what's known as RNA splicing or frame shifting. The protein, just seeing if any of that needs explanation. Yeah, I've put a little note about proteins. Proteins they're also known as polypeptides. Some of the papers we refer to them call them polypeptides, and they're complex molecules made up of chains of amino acids. Amino acids are the basic building blocks of proteins. There are 22 of them that we require to build protein. Some of them we derive from food. We break down food, animal proteins and vegetable proteins, and reuse those amino acids to make our own proteins. And some of them we can synthesize ourselves. So, just to continue, viruses evolved rapidly due to the high number of genome duplications undergone in a short spaces of time. So because they've subverted the cellular replicative processes, they're rapidly multiplying. That's the whole purpose of their existence. And in doing so, because those bases that I was talking about, the cytosine, adenine, and guanine, adenine, cytosine, uracil, that are RNA viruses, because the way the bases may get rearranged, there may be mutations, changes in the virus structure as it's replicating. And so therefore genetic sequencing of isolated viruses is important to identify new mutations and variants. Yeah. And experience has shown that most viruses, if they produce copies of themselves that aren't exactly like themselves, those copies probably won't be as efficient as the parents. But occasionally the new variant, the new strain may be especially pathogenic, or it may be less pathogenic than the parent strain.
I think this is probably the first time that you've mentioned variants, and I think this is one of the things that we will come on to, because I think we're all familiar with the various variants that there were, the Delta, the Omicron, and etc. Can you just indicate how significant would the variant have to be in order to constitute, as it were, a new variant?
Oh, that's true. There's a committee that actually decides whether this new form of virus is a new variant or a subtype, and so that's defined by virological experts. And they use certain criteria as to whether what is being seen is like entirely new or just relatively new. That's best understanding of the situation. So it isn't something that's intuitive. It has to be discussed and thought about and then pronounced.
And the identification of a new mutation or variant is dependent on the genetic sequencing.
Yes, exactly. So viruses can be seen with light microscopes. They can be identified through electron microscopes, and their genetic sequence can be established. The order in which the molecules are arranged is all important to what it is that the virus can do. And in special research laboratories, the viruses can be, if you like, enumerated in great detail, and those who are expert in this field will think, oh, that's interesting, that sequence of bases is different to the sequence that we would normally expect from this virus, and this we could be looking at an entirely new variant or strain of the virus.
Yeah, if you go on at the bottom of page 10, Doctor.
Thank you.
I think to a certain extent this is something you've already said, that
yes,
effectively they're parasites.
They're parasites. They need the internal environment of a host cell in order to create new virus particles, and the infectious virus particles are called virions. And periodically, maybe every few hours or every few days, new virions are discharged to the exterior of the infected cell, and so therefore the cycle of viral infection is perpetuated.
Right. That's probably a point to stop, my lord. If the next sector is slightly lengthy.
No, not at all. Very good. Thank you, Dr. Croft.
Thanks, Andy.
Thank you, everyone else. We will adjourn now until 9 o'clock. It's 9 o'clock, 10 o'clock tomorrow morning. I apologise. Thank you very much indeed.